by the YouTube link that has been sent to you. So, Vadakkam, a very warm welcome to each one of you to the pre-conference of CAHOCON here at the magnificent venue Frontier Lifeline Hospital, Chennai. I stand before you not just an MC today, but also a fellow traveler on this journey of bringing quality in rehabilitation. Allow me to introduce myself. My name is Dr. Rimsha Sindiki. I serve as operations head at PMR at Indian Spinal Injury Center. It's a multi-specialty hospital at Vasant Kunj, New Delhi. So, my role is like, every day I see the beautiful intersection of clinical excellence, patient experience, and systematic quality. But more personally, I'm proud to be one of the core group members of Quality, Rehab Forum. So I request you to please put your hands together as we have quality members joining us here today. This forum started with a very simple but a very powerful belief that every patient that walks into a rehab deserves not just care, but consistent, measurable, and compassionate excellence. So I think we started with this small thought, but it's getting bigger and more powerful with support of each one of you. So, quality is just not a department. It is a daily decision. And for the last several years, I have been a part of these decisions. So when I look at this gathering, each one of you, I'm sure you have joined here not because you were supposed to be here, but because each one of you chose this belief and you are here. So I welcome you all to be a part of this beautiful gathering, and I think we're going to have a beautiful lectures ahead. So let me put my heartfelt gratitude, a huge thanks to the hospital. This hospital has been very kind enough to provide us this platform and provide the all guidance and support so that we could all gather here today. Thank you so much, Sandhya ma'am. I must thank you, ma'am. She's the vice president of the hospital, and she's a very, very strong leader, very compassionate, and I see her guidance support right from the moment we thought of organizing this. She has been amazing, incredible support throughout this. Coming to the theme of this pre-con, this is Heart of Quality, Rehabilitation Excellence in Action. Can you just notice the word heart? Quality is not about cold checklist. It is not a bureaucratic audit. It's the heartbeat. It's that steady, rhythmic, life-giving thing that you feel. It's the pulse that runs through every assessment, every therapy session, and every discharge plan, every follow-up. I'm sure most of you who have joined here are clinicians. You would resonate with me on this thought. And let me come back to the excellence in action. This is just not about, putting us the problems that we face. No, it's living them. We feel that there is some challenge, we improve it, and the decisions we make, it is continuous. It's not a day story, all right? So in rehabilitation, quality is measured not in protocols, but in progress, one small win at a time. Without further ado, once again, I would like to thanks this hospital and Madam Sandhya for this beautiful event. And last but never the least, I welcome all the faculty members who we are going to listen, and I'm sure they're going to take us through the incredibly amazing, knowledgeable, enlightening sessions. And thank you so much for the delegates. You are the torchbearers, changers who are going to take this ahead. I once again welcome you all, and I wish that we have a great learning sessions ahead and hope to see you within interactive sessions. Can I have the video from Kaho? We would like you to have a look at the beautiful video that Kaho have prepared. It's about how we have started the journey as quality professionals. Thank you so much. And sorry, we started a bit late, but thank you for your patience. Thank you so much.
A new dawn, a new horizon. together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, Kaho, your healthcare companion. Kaho, standing right by your side. Kaho. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Whatever we need, no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a
We have a
goal,
goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive to march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, Kaho, your healthcare companion, standing right by your side.
So that was the Kaho anthem. And
A new dawn, a new horizon.
so excellence in healthcare, is never an accident. It is the result of high intention, sincere efforts, and skillful execution. That's what Kaho aims for. I cannot move ahead without remembering the legend, Dr. K.M. Cherian. He was the first one who brought, the excellence in cardiac care in India. He was the first one to perform the cardiac surgery. Please put your hands together as we remember Dr. K.M. Cherian. So taking the torch further, we have Madam Sandhya Cherian, who has been the torch bearer. She has, put this institution to another level with her all compassion, care, and excellence. I request you all to please give a big hand to Madam Sandhya, and I have this indeed privilege to invite her on stage to please enlighten her with the golden words. Thank you so much, ma'am. Thank you. Please come to the stage.
I'd like to also, introduce my brother, Dr. Sanjay Cherian. He's our senior cardiothoracic surgeon, and so I'd like you to also put your hands together for him. So good morning, distinguished guests, esteemed speakers, partners, and dear colleagues. It is my privilege to warmly welcome you all to this CAHOCON Global Rehab Quality Forum. At the very outset, I'd like to take this time to acknowledge and thank our patrons, Dr. Vijay Agarwal, the President of Kaho, Dr. Lallu Joseph, the Secretary General of Kaho, and the entire leadership of Kaho, whose vision continues to guide us, strengthen quality and patient safety across healthcare in this country. A very special and heartfelt welcome to Dr. Saril, the chairperson of the Kaho Global Rehab Quality Forum. Dr. Saril, your passion, your leadership, clarity of vision have been the driving force behind bringing this initiative to life. Your depth of knowledge, practical insights continue to push the boundaries of rehabilitation excellence, and we are truly privileged to have you here with us. Though he was in Ahmedabad, it was only through your guidance that I could really implement your vision here through my team. So thank you so very much. I'd like to also welcome Dr. Salomon Chandrasekharan, the co-chair of this forum, and Dr. Komal, the secretary of this forum. You both have been very helpful and truly helped position rehabilitation quality at the center of healthcare, where it rightly belongs. Dr. Salomon lives in Abu Dhabi, and therefore he could not be here physically due to the war situation, but he has joined us virtually. Thank you, Dr. Salomon. Thank you, Dr. Natesh, who's our Chief Operating Officer. I was discussing with him about hosting this particular CAHOCON conference here at our venue, and he was very receptive, very enthusiastic, and so thank you, Dr. Natesh. He has another meeting to attend and hence couldn't be physically here, but he will be joining us during the valedictory function. Thank you, Rosemary and Gopinath, for your constant support and helping us with all the arrangements. I'd like to now take a moment to welcome our exceptional lineup of distinguished speakers, each of them bringing a very unique expertise and experience to enrich our discussions today. Your contributions will undoubtedly add immense value to this conference. As you can see, a lot of thought has been put in by Dr. Saril, Dr. Salomon, Dr. Komal, Dr. Veena, and the entire Rehab forum to ensure that various topics covering the entire spectrum of rehabilitation, like cardiac, ortho, neuro, renal, geriatric, OBG, oncology, are all being discussed here. It just proves that recovery is multifaceted, and that a multidisciplinary team and collaboration is required, and it is the cornerstone of a meaningful outcome. My sincere appreciation also goes to the rehabilitation technology partners whose innovation is redefining and in the way care is being delivered. From advanced equipment to intelligent solutions, your work in enabling clinicians to achieve better, faster, and more precise outcomes. Your collaboration ensures that we remain forward with our thinking, be adaptive, and ready for evolving in our needs of healthcare. A special mention about Dr. Komal for conceptualizing an interactive quiz, which is going to be held sometime this afternoon. And we all know that learning is most impactful when it is participative and it is enjoyable. As part of today's program, we will also be celebrating the Quality Champion Awards, recognizing individuals and teams who have gone beyond their commitment for quality and patient care. These awards are not just acknowledgements, but these are stories of dedication, perseverance, and the pursuit of excellence. They remind us what is possible when passion meets purpose. As we move on through the sessions today, I encourage all of you to engage actively, share your experiences, ask questions, and build connections. Conferences like these are not just about knowledge. They're about community, collaboration, and collective growth. I'm confident that today will be a day filled with meaningful discussions, fresh perspectives, renewed inspirations. Let us together continue to strengthen the role of rehabilitation in healthcare and ensure that every patient we care for has the opportunity not just to recover, but to truly live well. So thank you for all being here, and wishing you all a wonderful and enriching conference. Thank you so much.
Thank you so much. I completely align. As ma'am rightly said, it is all about collaboration, community, and fresh perspective. I hope we have that today in our sessions. Let's move to the very sacred moment of lamp lighting ceremony. So lighting a lamp, signifies dispelling the darkness. In rehabilitation, what is darkness? Um, yes, a bit of, disability, maybe despair and poor outcomes primarily could be one. So let me invite on stage all the core group members, ma'am and sir, to please come forward and go do the lamp lighting ceremony, please. Please give a big hand. Let's give them that an energy from your side. Yeah. Dr. Sanjay, please join us.
विदिताखिल शास्त्र सुधा जलधे महितोपनिषत् कथितार्थनिधे हृदये कलये विमलं चरणं भव शङ्कर देशिकमे शरणम् करुणावरुणालय पालय मां भवसागर दुःखविदूनहृदम् रचयाखिल दर्शन तत्त्वविदं भव शङ्कर देशिकमे शरणम् भवता जनता सुहिता भविता निजबोध विचारण चारुमते कलयेश्वर जीव विवेकविदं भव शङ्कर देशिकमे शरणम् भवयेव भवानिति मे नितरां समजायत चेतसि कौतुकिता मम वारय मोहमहाजलधिं भव शङ्कर देशिकमे शरणम् सुकृते धिकृते बहुधा भवतो भविता समदर्शन लालसता अतिदीनमिमं परिपालय मां भव शङ्कर देशिकमे शरणम् जगतीमवितुं कलिता
So next in line is a very special and a very emotional moment. We all couldn't have been here without the vision of a leader, Dr. K.M. Cherian. This is all possible because someone years ago thought of something so meaningful. So it is such an emotional, such a special moment, and I feel so honored to be here and paying a tribute to Dr. K.M. Cherian for being the legendary person for bringing this to life and bringing so much excellence, care in cardiac surgery can we have a video paying a tribute to Sir?
The legendary Dr. K.M. Cherian, born on the 8th of March 1942. Dr. K.M. Cherian, also popularly called as Dr. KMC. What an incredible journey it has been. His birth was predicted to his mother by a tribal man much before his birth. The tribal man had said that the child would be a boy and that he would become a well-known heart surgeon. He was born into a family of 5 children. After completing his primary education, he was sent to a boarding school. Pre-university was in Sacred Heart College, and he did his MBBS from Kasturba Medical College, KMC in Manipal. He pursued his MSc, which was from CMC Vellore, and he then got married to Celine. Moving to Australia was a major landmark in his profession. He worked at the St. Vincent's Hospital in Sydney, Australia, and also got the opportunity to work with the world-renowned doctors. After a few years in Australia, he decided to move to New Zealand, which attracted talent from across the world. His true talent and passion as a cardiac surgeon came to limelight only after his training at Australia, New Zealand and USA. Leaving a lucrative career behind in Australia, New Zealand and USA, his passion drove him back to India to serve the country in 1975, when he did the first coronary artery bypass surgery, which was a major landmark in the history of cardiac surgery in India. This attracted a lot of media attention, and Dr. K.M. Cherian, the great cardiac surgeon, was born. He was acknowledged by the world for his superlative skills. He had the opportunity to meet political leaders both from India and abroad, and also got the good fortune to be the surgeon to both the presidents of India, Gyani Zail Singh and Shri Venkataraman. He was honored with Padma Shri in 1991. His name was carved on a stone in the island of Kos in Greece. To honor him in the international arena during the World Cardiothoracic Conference, this is again a unique lifetime achievement. He is the founder of several institutions, starting with the Madras Medical Mission, the Pondicherry Institute of Medical Sciences, and he has set up other institutes such as the Parumala St. Gregorius Cardiac Unit, the Dr. K.M. Cherian Institute of Medical Sciences in Kerala, and the Study Lekol International School in Pondicherry. He has mentored many surgeons in India and abroad. In all, this legend has influenced, touched, and saved many thousands of lives.
Life so beautifully lived deserve to be beautifully remembered. Such a beautiful, touching video. And I know that he was a great surgeon. He is a great mentor, and he will be the inspiration to generation. Please put your hands together as we truly enjoyed the beautiful video. So let me take you to another video, which is another very special video by a patient who has gone twice for the cardiac transplantation. I must say that it is not a video of a patient. It is a story, a winning story of the surgeons, doctors, nurses, staff, management. You know, it is to be celebrated. So please put your hands together as we are going to witness a celebration story of a patient.
Hi, my name is Reena Raju. I thank you all for inviting me to be a part of Kaho. A special thanks to Sandhya Cherian. Sandhya ma'am, thank you for giving me this opportunity to share my journey with you all today. I'm born and raised in Bangalore, and I've been a sports person all my life. And I have played field hockey, went on to represent my school, taluk, district, state, university at the national level hockey tournaments. I've not known a day where I've fallen sick and not gone to school or college. I've been leading a very fit and active life, but at the age of 25, I was diagnosed with dilated cardiomyopathy, DCM. I not only had to learn to pronounce dilated cardiomyopathy, but I had to learn to live it. It came with many challenges. My heart was functioning at only 15%. I had fluid restrictions, a cocktail of medicines that I needed to take every day. I could barely breathe, and walking was very challenging. It always felt like I was carrying a heavy dumbbell. I couldn't sleep, and life was incredibly challenging. But being a sports person, I learned to apply the same attitude as a patient as well, and I took my illness as a sport. And I knew that it's not just about the victory, but it's also about the fight. By God's grace, I went on to survive for almost 4 years with heart failure. In 2009, my doctors said that I needed a heart transplant. I did not know anything about heart transplant, the concept of brain death and organ donation. As I got registered on a waiting list for an organ transplant, my family members and I also registered ourselves to become organ donors, because that's when we understood the value of organ donation. But since there was a severe lack of awareness on organ donation in our country, and I was not getting a suitable donor heart in my home state, we researched and we got to know about Dr. Cherian. The world-renowned cardiothoracic surgeon was already doing a lot of heart transplants in Chennai at Frontier Lifeline Hospital. So we flew down to Chennai, met Dr. KMC. As a patient, meeting him gave me a lot of hope. I felt that I could beat death and come back to life. And in 2009, I underwent a successful heart transplant at Frontier Lifeline Hospital. In 3 months, in 3 days, I was made to walk, I was mobilized. In 5 days, I was singing for my doctor at the ward. And in 15 days, I was back in Bangalore with a precious donor heart beating inside me. I'm incredibly grateful and thankful to the transplant team and the rehab team at Frontier Lifeline Hospital, because after 4 years of going through a heart failure, my body had been through a lot. It was difficult, but with proper care and guidance, I was able to get back to fitness. 3 months post-surgery, I asked Dr. KMC if I could cycle, and he said I could. So I got on my bicycle after many years and cycled. That was an exhilarating experience for me. There was no stopping me after that. I went on to do marathons, cyclothons. I've parasailed, done a 13,000 feet tandem skydive, which was amazing. Went on to represent India as the first woman transplant athlete in the 2017 World Transplant Games and the 2019 World Transplant Games. Fitness has helped me as a patient to lead a normal life as much as possible, despite the immunosuppression and the anti-rejection medicines I take, the challenges of infections, organ rejection, many other challenges that I go through as a patient. Being fit every day has helped me lead a normal life. In 2017, I developed CAV due to the side effects of all the medicines I was taking. So I had multiple cardiac arrests. I was put on a ventilator, IABP, ECMO machine, the VA ECMO, and on a supra alert for a suitable donor heart. on the ECMO machine, I remember indicating to the nurse to give me a pen and a paper. And I have written to my doctors about the medicines that would not work on me, love notes to my family members. And I cooperated with the nurses and the doctors, and I underwent a successful second heart transplant. But unlike the first heart transplant, the second one was even more challenging. It felt impossible for me to walk because of the VA ECMO. I had massive wounds on my legs. I needed like 3 to 4 nurses to help me even get up and walk a little bit. And again, I had to go through a month of physiotherapy at the hospital. The cardiac rehab team helped me every single day to walk, slowly get on the treadmill, cycle, do my breathing exercises. It took a lot of effort, but within a month's time, I was, in 15 days post the surgery, when I could get up and do a little bit of physiotherapy, I was dancing to Jimmy Ki Kamal, wearing the hospital gown. And in 1 month, I was back again to my hometown with a donor heart beating inside me. Everything I do is in memory of my donors and donor families. And I wouldn't be here today without the expertise, the care, and the guidance of Dr. K.M. Cherian, the incredible transplant team at Frontier Lifeline Hospital, the physiotherapists, and the cardiac rehab that I have had. I feel super blessed. And even till date, I have my good days, bad days, not so great days at all, life and death days, and days where I need to rest. But every day, I try my best to do a little bit of exercise. The days I'm feeling like great, there's no stopping me, of course. But I continue to be fit because I know that fitness has helped me physically and mentally lead a normal life. So I hope sharing my journey with you all today at the conference encourages patients to never give up, no matter what illness they are fighting, and that there is always a road to recovery if you work with your team of doctors, physiotherapists. You can lead a normal, healthy life. I wish you all the very best, and thank you so much for making me a part of this conference. Thank you. God bless. Hi.
So I think it's one of the million stories, where we are remembering Dr. Cherian. And I think it's an honor to see two generations, Dr. Sanjay Cherian, Dr. K.M. Cherian, to be in the same, frame. So we are so honored to have you with us. He's right next to us. So I think it's a story of resilience, motivation, and a good, amazing teamwork that she had at the Frontier Lifeline Hospital. If you're listening me, Reena, I wish you all the best, and you are doing a great job. Thank you so much. And before we move ahead, I would like to invite Dr. Saril, Sandhya ma'am, to please come on stage as we request Dr. Saril to please present a token of gratitude to Madam Sandhya. Please come forward. Please, a big hand for ma'am.
Sir, please, sir.
Thank you so much, Raminda. I didn't expect that. Thank you.
So, next in line, as we are about to conclude the inaugural ceremony, it's a very, very special national anthem. Why I am calling this very special? Because it is sung by people with disability. So this national anthem shows that it is not what you're born with, it's what you overcome. So please rise as we witness a very, very special national anthem. And thank you, Dr. Saril, for introducing this national anthem to me as well. Thank you. So, it is indeed another special moment for me to introduce and welcome Dr. Saril. He's the chairperson of Kaho Global Rehab Quality Forum and a senior general manager, advanced rehab services at KD Hospital, Ahmedabad. But he's much more to this. He's my mentor, and I think all the group members would agree that, when we started this forum, it was his idea, his initiative, and since that day, it was years back, even today, he is so enthusiastic. I can't tell you. For past 3 or 4 months, I think he has been sleeping after 3 a.m. He messages me, this has been done, this is all over. And I'm like, when does he sleep? When does he do his normal job? Because I'm cribbing every day about my hospital operations and then working on quality. But I think he's the light behind the show, and it is my privilege and honor to welcome him on stage to present his words. Thank you so much. Please, a big round of applause for Dr. Saril.
Namaste all. It's quite an emotionally overwhelming moment, and all the kind words for the forum and for all of us joined here. We are all the torch bearers and we are all the change agents. I would at this moment, I'm not really intending to have a real PPT kind of a presentation or something, but my intention is to welcome all of you to a revolution called Kaho Global Rehab Quality Forum. Why do we do it? What lies ahead? Let's try to understand that. A lot of the clinicians over here and virtually who have joined us would probably understand quality is usually when there is an audit. There are some reels I have seen where, even the movie scenes are collated together and they say everybody is rushing the 3 days before, like the way we prepare for exams. Just before the, audit, be it JCI, be it NABH, or be it SCARF, anywhere in the world, people start thinking about quality all of a sudden when we have to really face auditors, external auditors or internal auditors. But something I noticed much earlier in my career is that when the auditors come, sometimes they even, I'm sorry to say, they discount the physiotherapy department. Why I'm saying that, most often it is used to be only physiotherapy department. Now we are evolving as the rehabilitation. We are, if I can use a word, we used to be, or we were, underdogs. Nobody used to give us the credit. And many auditors I have seen, with all due respect to all the auditors, I'm also one of the auditors, is that they would say, if I have time, I'll just go to physiotherapy and just have a look. So it was never part of the planner of many organizations. Those were the days, my dear friends. We decided that nobody is going to come serve us anything. If we don't stand up for ourselves, nobody is going to respect us. I am sure a lot of people have faced a lot of problems. So I really remember at this moment, all my seniors, all of us who literally fought through a lot of less resource settings. When I say this, I was one of the initial batches of physiotherapy in Kerala, and we had literally nothing. There was not even a proper, medical college didn't give us that kind of a facility. So from that, to take a lead on a global platform, it's a long journey. And to understand that our profession has got a lot of specialities, lot of interdisciplinary, multidisciplinary team members, and develop that respect for each of us. All this is a long journey, actually. And I really remember and thank everybody who has helped us to shape our profession including our precious patients who made us believe that it is worth to be in this profession. So I congratulate all of you to have chosen rehabilitation as your profession. So a big round of applause for ourselves. Thank you. I'll take you quickly. So Kaho Global Rehab Quality Forum was established very recently in the year of 2024 in Kolkata Kaho conference. So the focus area of the forum include clinical audits and rehabilitation quality assurance. We will keep talking about these terminologies. So any point of time, if you are not able to, kind of conceptualize any of this, the typical quality jargons, I would say, please meet us. We are here to help you. We want to work with you and make the change. Infection control practices within rehab settings, standardization of rehabilitation documentation, patient safety and incident reporting systems. A lot of you might be doing it. Development of rehab key performance indicators, KPI, or what we call as quality indicators. NABH until 5th edition never had a mandatory KPI for rehab. But now in the 6th edition, there is one mandatory KPI for rehab. Just want to check how many of you are awake. Can you just raise hands if you know which KPI that is? 1, 2, thank you, 3. All right, so it's 4. So it's on FIM. It's a new added KPI. It's become mandatory. And everybody started noticing rehab because there is a new mandatory KPI. There's a lot of discussion. There's a lot of debate. Even in my organization, the quality team does not understand it quite yet. But we are in the process to educate everybody. And that's the mission we have taken up. We have to educate our own fellow members. We have to educate the whole world, especially the medical fraternity, that yes, we do exist and we do an incredible job, as you have evidently seen in the past few videos and the tribute that we have made, the special anthem. I hope some of you at least might have felt the goosebumps the way even I felt through that actually. It's amazing what journey our patients go through in their daily life. We sometimes are become so busy that we don't realize that what change we do to the society. So today is a day that we take a little rest from our clinics, come together, form as a team, and then we really thank all the patients, all our colleagues who made way for this. So this is the Kaho Rehab Quality Forum members for the 2024 to 2025. I have Dr. Joseph Sani as an occupational therapist, Dr. Komal Agarwal, Dr. Jeba Shakila, Dr. Rimsha Siddiqui, Dr. Sanjeev M. Padankati, Dr. Veena Kiran, and Dr. Lakshman from Nimhans. So all of us together started this journey along with Dr. Salomon and myself under the Aegis leadership of Dr. Lalu and Dr. Vijay Agarwal, the pillars of Kaho. The first annual conference was in 2024 in Kolkata. The theme was Quality and Patient Safety in Rehabilitation Services. A wonderful show put together by Institute of Neurosciences, INK, Kolkata. We instilled a multidisciplinary approach to quality improvement and patient safety within the rehabilitation sector that year, and that's the very year we launched this forum. And we had clinical excellence, patient safety, strategic growth, hands-on experience, and the best part was we really focused on quality, and we got even a medico-legal person to teach us about what are the medico-legal consequences if you're not careful with that. And we even had a nurse who was educating us on the basic infection control practice. So it was a wonderful conference altogether. And these are all the various kind of activities that we have been doing through 2024. So a lot of them. And the second annual conference was a magnificent show, all thanks to Dr. Rimsha and the Institute of Spinal Injury Center, New Delhi. We had a theme called Quality Driven Rehabilitation for All, hosted by ISIC New Delhi. This was in 2025 at the same time. So every year in April, please mark your calendars, be with us, let's meet, let's join hands together. So we had an overwhelming response within over 300 on-site participants and 200 plus virtual attendees. And We were declared as the best forum in Kaho. There are a lot of other forums like Pharmacist Forum, the Biomedical Engineers Forum, Purchase and Supply Chain, Anesthetist Forum. So there are a lot of, the professionals are coming together and creating forums, and we are one among that. Second annual conference in New Delhi, these are all the topics. The strategic focus that we developed or evolved is knowledge dissemination, technology awareness, professional capacity building, community engagement. So we have started doing something called Rehab Knowledge Nuggets, because as I said, we need to educate ourselves and we need to educate everybody. So we release these during a certain World Health Day. So during that time, these kind of, the nuggets are released. It basically teaches people about what is speech therapy, what is swallow therapy, what is occupational therapy, what's physiotherapy, and so on and so forth. And these are some of the examples. So we had one for the geriatric people on that day. And we also did for mental rehabilitation. It's the psychological rehabilitation is also part of it. We have another series called Rehab Insight. And you can see and you will experience today a wonderful impact of music therapy, which is a new addition to rehabilitation sciences. We also had neuropsychology sessions. And also we had Dr. Anas from UAE who has taught us about quality improvement projects. How do you do quality improvement project? How do you publish that? How do you present that to other people? We intend to repeat these sessions, so we welcome all of you to please attend. These are all free webinars. So it happens in our own sweet time. The free webinars, please encourage everybody to attend these sessions because education has to be free, right? Rehab Tech Talk is a proud initiative from us. You would have heard of TED Talks. So in that alignment, we have made Tech Talk. And we partner with a lot of advanced technology across the globe. And we have done brilliant sessions on robotics, EMG, FES, and so on and so forth, even zero gravity treadmill, things the innovators talk about it. It's not the vendors or somebody, it's the innovators, the R&D people talk about it. We also have started a professional development program, PDP, enhancing quality in physiotherapy. So this is conducted in DSU University in Bangalore. And so we teach the teachers. We actually, develop the faculty so that they go back and teach people quality and safety in the college. If you are taught quality and safety in the college, you tend to follow that once you start practicing. We also had an international certification program for swallow therapist. Some of you might be even hearing this terminology first time, called deglutologist. And we also were part of the International Deglutology Conference, actually, which has happened in IDC conclave, which has happened in Bangalore. There was a CME on scientific principles and clinical applications of TheraBand. A lot of us think that it is just color bands. Many people don't know the physics behind it. So we tend to educate that. So any of you who wants to partner with us, just give us a ring. We'll be with you. We will arrange everything for you. We'll get the trainers. These are trainers who have certification for being a trainer. These are not just practitioners. There's a big difference between a trainer and a practitioner. American accredited CME on pulmonary rehabilitation is one of the first time that we have got Sakrawal Hospital, where I have been working past 11 years before my current assignment in Gujarat. We have got American accreditation for a pulmonary rehabilitation. This is the only institute in the entire Asia who's got this kind of an accreditation. So it's a rehab accreditation. We may not be knowing. So anybody who wants to do a rehab accreditation in pulmonary rehabilitation, in cardiac rehabilitation, we can help you. We travel the tough path. It was very difficult for an Asian country to really be accredited from America. But now that we have learned how to do it, we want to encourage all the other people to do that. And India's first CME on robotic assisted gait training was also organized by us this year. And community outreach. And this was a wonderful, humbling experience where we did a geriatric wellness camp. You know what we did? We even got a audiologist, a music therapist, a psychologist, a geriatric physiotherapist, many people together. We all joined hands together. We actually went to an old age home. We developed a geriatric evaluation, a comprehensive assessment, and guidance based on that. So one full day spent with the community, and that's something that we have done. So this is also shows the depth of activities that we do. We really walk the talk, my dear friends. Now the way forward, this is my last slide. Exciting, amazing news that I want to share with all of you. Many times NABH comes to our centers. We do not have any standards much even in NABH. And there are not many accreditation bodies. So from the time we started, we have been getting a lot of queries that when will you guys start with an accreditation? So instead of an accreditation, we are starting with a Center of Excellence certification program. And as the phase 1, we are going to launch it day after tomorrow in the CAHO conference. This is a grand launch of the Center of Excellence. CAHO Core, it's called CORE, Center of Rehabilitation Excellence. So any center who is working in a hospital can actually apply to that, and there will be audits. We will help you, we'll handhold you to achieve the highest possible quality standard that you can set the benchmark. And it's an ongoing process. There will be re-accreditations, re-certifications. So this is the way that we are going to get very, very strong. And we will be the first one in the entire globe to really come up with something of this sort, which is so focused for the Rehabilitation Center of Excellence, quality and patient standards. So this is already formed. There have been a very, very stringent, so that's one of the reasons, as Dr. Rimsha was telling, that I couldn't sleep past 3-4 months. We have been really, really working on this, that we knew we had to be right in the first time. We are launching it. We did not want to lower our standards. The whole world, the nation has to understand that our standards are really upheld. All of us will work towards this, and we'll start a lot of training programs around this. We'll work with all the colleges. We are happy to come to your place and teach our students to understand what are the standards, how to achieve the standards, how to maintain the standards. So Nutri-Habilitation is a joint venture that we are starting with the Nutritionist Forum. That is also going to happen tomorrow. Clinic, if you see the spelling, clinic IQ. So clinical intelligence plus quality is excellence program. So this is something we are going to start, and we are going to launch this program in this month in Chitkara University, Punjab. It's a one-day boot camp where everybody comes together and learn all the quality tools that can be applied. And once we launch this program, we also will learn from that, and we plan to conduct this in different parts of India. So we again welcome all of you to please join hands with us and help us with this. Quality advocacy in IDC, Bangalore Physiotherapy Network, Indian Association of Physiotherapists, OTCON, all these various forums, we are joining hands with them. And we want to really grow. We want to really make everybody embrace quality and patient safety. And that's the way, my dear friends, that to gain the much due respect that we all really, really aspire for. Respect is not something we can demand, right? We have to increase our own quality, and the respect will automatically come. And I have a few of my friends who has worked with me in Sakraval Hospital. It's a Japanese hospital, if you didn't know. It's a joint venture, and it's a Toyota's 100% Japanese hospital, where I had the privilege to really develop all this and learn a lot of Toyota principles and Japanese techniques. We have tried it, we have tested it, and over 11 years, this is all really, really evolved. So whatever we talk is from our experience. If we could do it in one place, we can do it in every place. And that's the confidence that we have. As I said, these are some of the CMEs on ISTM, kinesio taping, and we are going to do a dynamic taping. Many of us may not have heard of that, from Dr. Ryan, who is the inventor of dynamic taping. So what we do is we get the catch hold of the inventor of a particular technique or something, and we do it from them and not their students. So we really want to hear it from the horse's mouth, that why did you develop? The passion will be another level when they do that. And Rehab Center of Excellence, we want to really start sharing the stories of CMC Vellore, Sakraval Hospital, ISIC Delhi, Ramaiah, HCH, Sukino, Nimhans, INK. I probably might be missing out some of the names, but trust me, these are all the people who are doing a great job in the country. So we would want to welcome them to come share their success stories so all of us can learn from that. And international collaborations, we are planning to join hands with World Health Organization. There's a WHO Rehab movement which is happening. So we are also, but we need 3 years as an eligibility criteria. So we are in our 3rd year. We're working very hard towards getting our recognition from WHO as well. And the 4th annual Rehab Quality Conference is in 2027, April. It will be in Mumbai. So I invite all of you. We have to continue this journey. This year, we have chosen our own Chennai, and we are really, really grateful. And we did something exceptional this time. We decided to invite all the stalwarts of Chennai, all the superheroes and queens of rehabilitation landscape in Chennai. And we wanted all of you to come together and take the lead forward. So academicians, clinicians, everybody, welcome to the show. And also people who have traveled very far. You know who's traveled the farthest in this crowd? So there's a gentleman from Dehradun. So please give him a clap. And the best part is he didn't even ask me for even 1 rupee. He's just bearing all the costs. So that's the passion that we are really celebrating today, actually. We really believe in this, passionate enough, and do that. We have Dr. Prasanna, who was just in IFNR yesterday. A lot of people were making excuses. IFNR is happening. I cannot do it. He has traveled. He had a rough night, but he has made it today with us, actually, from Mumbai. And so a lot of people from Bangalore and Kerala, different parts who have come all over. And especially I thank the virtual platform. All of you who are probably accessing us through the YouTube link. And I'm sorry about some kind of technical glitches. You know, AI cannot overrule. So we just wanted to prove that it's the natural intelligence which will win at the end of the day. That is how the technology sometimes cannot be the winner. So we had some technical glitches. Sorry about that, but we are getting on with a wonderful day of learning. This is a journey of 1,000 miles. We are beginning with a single step. And this is a QR code. I'll share with all of you. This QR code will take you to the forum. And in the forum, you will get to know all our activities. And our website is getting developed. You can join as a free deemed member as part of this Global Rehab Quality Forum. So it's a free membership as of now. A few years down the line, as we really grow, we probably might ask you to pay some money, actually. So take advantage of this moment at this time. And thank you so much for a wonderful day. And I really thank the brilliant array of the speakers. So last year, what we did is we got the main people of IAP, IAPMR, IOTA, OPI. If you have not heard of OPI, how many of you know what is OPI? It's the Association of Piano. ISHA, it's the Association of Speech and Language Pathologists. So all the office bearers of these associations came together and they all stood together in one stage. And I think we take the credit for that in the whole country. For the first time, we could get all different professionals of rehab to really come together and shake hands. And we did this entire theme around interdisciplinary or multidisciplinary rehabilitation in ISIC last year. So that was the theme last year. This year, we raise our benchmark by talking about super specialties. You know, I don't know how many of you ever heard of or practice renal rehabilitation or geriatric rehabilitation or women's health. We all probably stick to the basics of what we learned, but quality improvement projects help you to go to the next level. You will be landing up in something new. So this year, today, we are going to explore super specialties in the morning half, and afternoon, we are going into tech talks. So we have some Make in India tech talks. The people who have innovated are going to come and talk to us. And please make best use out of this. And we don't leave anybody without a gift. Can anybody guess what is the gift that we have kept for you today? For the on-site people. I'm sorry about the virtual. We have to give you a virtual gift. So we thought of, usually in conferences, all of you as you walked in, you might have probably expected a bag. I might have at least 105 bags in my house, which I give away to people, donate it. I don't know what to do with the bags, what to do with the badges after the conference. So we didn't want to waste and be a burden to the carbon footprint of Earth. So we are doing something very simple, very beautiful. We are making a caricature portrait of you. So from 11:30 onwards, one floor above, we have arranged a caricature artist. We welcome all of you. Until 3:30, the artist would be available. Please go meet the artist, make a beautiful caricature portrait of yours. If you didn't like it, ask him to make one more. But I don't guarantee how it will come out, because it's a cartoon, right? So you will have to really, really, embrace that. I'm sure this is something that you would hold it for life. And this is a simple gift from all of us. Please accept it. Thank you so much for coming here and gathering today. Over to you.
Thank you, Dr. Saril, for putting years of hard work, efforts, and experience in these few slides. And thank you so much. I would request Madam to come forward and Dr. Sanjay to felicitate Dr. Saril. And I request all the participants to please keep the claps coming for this moment. Thank you so much. Thank you, Sandhya ma'am. Dr. Sanjay, thank you so much. It's time for the sessions to take over. Before I conclude, I just want a small experience that ISIC Multi-Specialty Hospital, we have almost 300 patients footfall every day apart from IPD sessions. So when we started with quality processes, I'm sure most of you would agree to me on this. Clinicians used to say that we have so much to perform every day. Why so much of paperwork, processes, so much of documentation. It was years ago. But now I do get a lot of requests. Where can we attend the course for this? So I try to connect them to Dr. Saril. So I think that's the chain, and I take it as a victory. It is indeed a process, and I'm sure we will achieve this together. So thank you so much for being with us today, and I'm sure the heart of the quality is going to beat a little stronger in this room. And I would like to request Professor Veena to please come on stage. She is also one of the core committee member from Kaho, Global Quality Rehab Forum. She's a professor at Ramaiah College of Physiotherapy. She's a chief cardiac rehab program from Ramaiah Hospital, and also a visiting scientist to Toronto Cardiac Rehab. Ma'am is an excellent faculty member, an amazing clinician. I don't know how she's managing today without her consultation. So she's amazing clinician plus a very focused and dedicated quality professional. Please, ma'am, I welcome you on the stage. Thank you so much.
Very good afternoon, good morning everyone, and this is also to all the participants who are watching us online. So if there's any glitches for anybody, even on online, please do ping in to one of the members, one of us. My dear esteemed colleagues, the clinicians and the champions of quality, welcome to the quality pre-conference workshop of CAHOCON. The theme of this time is Heart of Quality, Rehab Excellence in Action. I'm honored to facilitate the session on distinctive rehab specialities. Today, we acknowledge a fundamental truth, that is rehab. It is no longer an afterthought of after surgery or after an acute care. It is a very engine of long-term recovery. However, for that engine to run effectively, it requires a rigorous framework of quality assurance. The future is just not about doing rehab, it is about measuring and perfecting it. Let's begin our journey through the specialized landscapes of recovery. So, the morning session, what we have power packed full of rehab specialities, how we do quality assurance in that. And we are going to mix it little bit not only with cognitive overload, we're going to have a little bit of quiz in between, and we are going to have some music therapies, so we are not going to load you so much. And so when we are going to introduce each of our speakers, and once they finish, we have an award for the best speaker of the day also. So then after the speaker speaks, we are going to have a poll. So we are going to put a QR code on the screen. So I request all of you to go to the QR code and score yourself on the speaker. So that will be done after every speaker. And yeah, so to kick us off, we look at the ultimate second chance in medicine, the heart transplant. Quality here is a razor edge between physical conditioning and delicate immunosuppression management. And to discuss this quality assurance in this high-stake area, please welcome Dr. Sanjay Cherian. He's a senior cardiac surgeon with a lot of achievements, outstanding awards, both at the national and international level. We request you to please come, sir. Please put a big hand for sir.
Good morning, everyone. At the very outset, I'd like to thank all the members of Kaho for organizing this, and special thanks to Sandhya as well for inviting me to be a part of this August gathering. Do I just slide this? Okay. So, in terms of my talk today, wanted to focus about the quality assurance in post-cardiac care, not just in transplantation, the importance of cardiac rehabilitation following heart surgery. So, starting with the transplanted heart's new beginning, just to give you an introduction to Frontier Lifeline in case you're all coming to our hospital for the first time. So, ours is a super specialty cardiac center that does an array of cardiac surgeries and cardiac treatment for starting from neonates to pediatric to the elderly. And I'm also happy to inform you that we just performed a heart transplant just 2 days ago. And special congratulations and best wishes to the entire team for making this happen. So, as we all know, heart surgery as a whole and heart transplantation in specific is a life-saving intervention, right? So it represents the ultimate treatment for end-stage heart disease and for heart failure. And when it comes to heart transplantation, we all know that the main aspect that we're looking for is to improve the survival. So survival gains have been very, very well documented, marked improvements in the long-term survival rates post-transplantation when compared to just pure medical treatment for end-stage heart failure. And also the improvement in the quality of life, where the recipients definitely experience a significant restoration in their functional capacity and their well-being. So I would like to highlight the crucial role of cardiac rehabilitation. As we all know, it's a standard of care which has been endorsed by several organizations such as the American Heart Association, etc. And there are proven clinical benefits where it improves fitness, the psychosocial well-being of the patient, and reduces both the morbidity and the mortality of patients following surgery of any kind. And most importantly, when we are specifically looking at rehabilitation and the importance following heart transplantation, we know that the biggest issue that we face is the problems pertaining to immunosuppressants. And we have clearly seen that rehabilitation directly counters weight gain, muscle atrophy, and other long-term problems pertaining to immunosuppressants. So again, in terms of the evidence for exercise based on cardiac rehabilitation, there have been several studies that have clearly shown the importance of the role of cardiac rehabilitation, primarily in improving the functional capacity of the patient. So when we look at the exercise-based cardiac rehab procedures, the main measurable factor that we look at is the uptake, the peak oxygen uptake, and which is seen as the gold standard for measuring the cardiorespiratory fitness. And several meta-analysis studies have clearly shown that with proper rehabilitation, there is an increase in the uptake of VO2. And this is something which has changed over several years, because we need to do away with the old belief that, after any form of surgery, especially in terms of transplant, we need to have a 1 month of complete bed rest, which is such an old dictum now. We all know that early rehabilitation and early mobilization is what actually helps the patient to get back to his routine at the earliest. So, addressing post-transplant complications specifically, one of the biggest issues in terms of cardiometabolic risks. So, as we all know, rehabilitation actually helps to mitigate hypertension, diabetes, dyslipidemia, and also the vasculopathy which happens after transplantation. And also, when you introduce rehab quickly, it actually reduces the number of hospitalizations which actually happen. So patients have fewer admissions to the hospital, and we've also seen that acute rejections and decompensated heart failure is seen lower in patients who are actually mobilized quicker and who actually go through an active rehab program. And also in terms of stroke and mortality, a regular structured exercise actually reduces the risk of strokes and also decreases the mortality rates in heart transplant patients. So boosting the uptake, the VO2, okay, the power of exercise. So structured exercise and training programs following transplantation directly reverses the end-stage heart failure problems that are associated, and it actually improves the post-operative recovery. Now, how do we ensure the quality in practice? All this theory that we spoke about is really good, but then how do we actually ensure quality? See, when we look at the challenges of cardiac rehab utilization, despite this clear evidence that I spoke about, the uptake of cardiac rehabilitation, okay, following any form of surgery, heart transplantation or lung transplantation, or even just heart and thoracic surgeries as a whole, still remains critically low. And when we look at the factors, we realize that there are 4 major factors which are actually the barriers. One is the physical barriers, such as infections, rejections, the side effects of medications, and fatigue of the patient, because we need to understand that the patient is really tired after going through a really big procedure like this. Second thing is the psychosocial barriers that we see. Patients actually go into anxiety and depression, and it's very, very difficult to actually motivate patients to get into a rehab program. Now, we all saw that video of Reena Raju. She's one of those heart transplant patients who was extremely motivated. We had done several heart and lung transplants, but then we had never seen a person who was so driven and motivated. So it's very important as rehab professionals that we're not just looking at treating the disease, but it's also very important to look at the psychosocial aspect of the patient as well. In terms of logistics barriers as well, because the transportation, the geography, the costs of rehab, these are things which actually prevent patients from actually taking up the rehab program. And also the system barriers like late referrals, and then the lack of standardized protocols that Doctor was talking about. So in terms of key quality assurance considerations, the first and the most important, I feel, is the timely referral. It is very, very important that we refer patients who have undergone very, very serious procedures such as heart transplantation to get referred as quickly as possible. So the earlier we do it, the better. So we would actually say 4 to 10 days post-discharge would be the best time to actually get them to start into the program. And an acceptable benchmark would be anything between 10 to 60 days, depending on how well the patient is actually recovering. The next important thing is in terms of the standardized protocols, evidence-based exercises. I would like to highlight the role of yoga and pranayamas, deep breathing exercises, which, trust me, really, really helps. I completely push all my patients to do not just their spirometry, but also their deep breathing exercises as suggested by yoga, and accounting for any form of incompetence and any immunosuppression-based disorders. Third, most importantly, is the need for a multidisciplinary team approach. Here, we always make it a point to involve the cardiac surgeon, the cardiologist, the anesthetist, the intensive care specialist, the nurses, the paramedical services, the rehab, getting all of them to come together and work as a team for trying to work out a specific specialized program for each patient, which is individualized for each patient, because it doesn't mean that every patient can do every kind of exercise. So it's very important to join the team, get together and see as to what best works for each patient. And fourth, the most important fact, not the least, but is patient adherence. It's very, very important to overcome those barriers that we had spoken about and to sustain the consistent and periodical long-term participation of the patient in these structured programs. Because what happens is that we see that patients initially, just after the procedure, are quite enthusiastic about getting into the program. And after a few sessions, maybe a month or so, they realize that, they start getting bored. And they don't have that compliance to come back and undertake this rehab on a regular basis. So this is something which is very, very important to ensure that as a team, we are able to motivate them and push them to do this. As ma'am mentioned, this is not just a one-day procedure. It's a long-term process to actually improve the quality of the patient. So when you look at the patient's journey from the transplant or from heart surgery to the complete recovery of the patient using cardiac rehab, the first thing is that the transplant surgical team itself, they hand off the patient, they go off into an early recovery phase. As I mentioned, within the first 4 to 10 days, if you're able to refer the patient to this CR team, the cardiac rehab team, and as I mentioned, they enroll into this program. It's a multidisciplinary program that they get into, so there's a clear assessment done, and after which they get into the rehab program. And it's not just doing the exercises, but also ensuring that there's constant monitoring of the exercise and tracking the progress of each patient. Now, talking a little bit about the future of post-transplant or post-cardiac surgery rehabilitation. With advancing research and practice, we are able to improve the long-term outcomes of cardiac rehab. And there's a greater focus based on longitudinal studies. So it's very, very important to not just look at what you are doing, but also look at what the other centers are doing, not just nationally, but also internationally, to see as to what are the best practices that can be brought together. The use of diverse exercise modalities, as I'd mentioned, it's not just in terms of just regular breathing exercises or respiratory exercises or hands and legs exercises and mobility, but also in terms of aquatic training especially. Hydrotherapy has come in a really big way. And the other thing is also in terms of the integration of technology. As we all know, AI, artificial intelligence, machine learning, ML, has come in a very, very big way. And I'm sure that if you're able to collate all the information that we get from all these different studies, and we're able to maintain the records of each of these patients really well, we'll be able to come up with a lot more different modalities of better treatment. And also remote monitoring devices, wearable sensors, digital platforms, which can all improve the process of cardiac rehab. So if I can just go through some of the KPIs, I'm not going to go through in detail, but then the very first thing, I put this slide as prehab, which is like before we get into the rehab itself, we talk about, pre-rehab, what happens. The first and most important thing is in terms of just attending the function. The session attendance is very important. We need to ensure that there is like a regular attendance of the patient to come into this rehab program. That itself is a big indicator. Next is in terms of other things like the functional capacity, the 6-minute walk test, or the protein intake, ensuring that the muscle mass is like maintained by using grip test or calipers. Psychosocial well-being, which is addressed. The time to first mobilization, as I mentioned, if I can give off some just key takeaway home messages that I can give you, is that please try and ensure that the patient gets into the training program as quickly as possible. The earlier the better, because once they get into a very relaxed mode, then it's very, very difficult to motivate them and get them into the rehab program itself. So time to first mobilization is very important. It's very important to also make sure that the hemodynamics of the patient is stable. Sternal stability. This is one more thing which is very important. From a physiotherapist's point of view, it's not just about doing exercises, but also noticing that if there is any change that you see in the patient, if there is some kind of wound issue, if there's any sternal instability, these are things that you should address straight away and bring to the notice of the surgeon or the cardiologist as well. The role of deep breathing exercises, spirometry, and the looking out for red flag recognition, as they mentioned, in terms of like fever or any sudden weight gain or any extreme fatigue, sudden cough, wound issues which are happening. These are things that the physiotherapist should also keep in mind. And the next thing is to go into phase 2, which is the phase 2 enrollment, to actually get them into the next stage of rehab. So in conclusion, in terms of cardiac rehabilitation, it's a commitment to a lifelong well-being session that we're looking at. We're not looking at a short-term program which is just to be done immediately after surgery. This is something which has to be an ongoing program which will actually improve the quality of the patient. So quality assurance in post-transplant cardiac rehabilitation is paramount for optimizing patient outcomes and for fulfilling the promise of transplantation, which is to improve the quality of life. So we need to close the gaps, which I mentioned, increase the referral rates, remove the barriers, and so that every patient has access to a structured cardiac rehab program. And implementation of standardized protocols, strengthening the multidisciplinary approach, and to push the patient to stay motivated. So hence we're able to achieve full potential, empower each of these patients to get to the highest possible level of recovery, function, and long-term health. So these are the references that I had used for my talk. So thank you very much. So I'd like to again thank you all for attending this conference, and good luck for this entire session. I'm sure the next couple of days you're going to be learning a lot from a lot of people in terms of rehab. And thank you once again for giving me this opportunity, and congratulations and best wishes to Kaho. Thank you.
Thank you, sir, very much. Cardiac is very close to my heart. So reiterating some of the things what you told about yoga, because rehab is incomplete without the whole team. You told that yoga, the integrated practice, definitely there are a lot of yoga, cardiac rehab clinical trials being running out all over. So I was a part of it, so I know the benefits of it. And we tell that the patient should not become bored. You told that, no? Same. So probably we should also involve some amount of hybrid model when we are training the patients. Then educating the patient. In India, we don't educate our patients. Patients don't know anything what's happened to them. It's not like that in Western countries. They know everything. Very important, because that is going to improve your adherence to your treatment program. And you can give us simple things like, ask the patients to cook their own food. Have a pantry in your setup. Have the nutrition on board, and ask them, let them make their own food for the day. So like that, things you can give them to improve adherence and make them interested in the program. Thank you, sir. Thank you very much. And I want to put the poll. There's a poll. Next slide. Next slide. Next slide. Yeah, wait, I'll tell you. Kindly, all the participants, please, even the virtual participants, please log on to the QR code. We need you to rate our speakers, because we are going to have an award for the best speaker of the day. So kindly, the virtual participants and all those who are here, please go on to poll. I kindly request the core team members to please come on the stage to felicitate Dr. Sanjay Cherian. The next session is actually on sports rehab, but I'm sorry to tell that Dr. Tyagarajan had some personal commitment, so then we will not be able to do this session right now. So we go on to the next session. The next session is the talk is on renal rehabilitation, so that's a quality assurance in renal rehabilitation. It is a rapidly evolving field where quality of life is directly tied to metabolic stability. Joining us from Ahmedabad to discuss this quality assurance framework in kidney care is Dr. Bharat Tiwari. He is a principal at Indian Kidney Diseases, ITS College of Physiotherapy. He would not be joining us on site, but we'll be playing a recorded video of his for his presentation.
Good morning, respected chairpersons, dignitaries and colleagues. I am Dr. Bharat Tiwari and today I will be speaking on quality assurance in renal rehabilitation. This topic is very close to my clinical practice at IKD-RC ITS, where we deal extensively with CKD, dialysis patients and post-transplant patients. So why renal rehabilitation needs quality assurance? Chronic kidney disease affects nearly 10 to 13% of the global population. These patients often experience reduced functional capacity, severe fatigue, and it leads to poor quality of life. Although exercise-based rehabilitation has proven benefit, it remains underutilized and non-standardized. This is where quality assurance becomes essential. Coming to focus on the Indian ESRD burden, ESRD means end-stage renal disease. So in India, approximately 2.2 lakhs new patients with ESRD patients are added every year. This creates a demand of nearly 3.4 crores of dialysis sessions annually. This enormous burden clearly highlights the need of structured rehabilitation and, more importantly, standardized quality protocols. In the article from the Times of India in 2019, where it states that no doubt there is an increase in number of CKD patients year-wise, but more concern is that the now youth are also frailing in the are getting involved in chronic kidney diseases. So now coming to the classification of stages of the CKD. CKD is classified into 5 stages based on the estimated GFR. These stages helps us identify disease progression, stratifying the rehabilitation needs and predict the outcomes. Fifth stage is end-stage renal disease. So where there is a need of renal replacement therapy. Only 2 renal replacement therapy options are there. One is the transplantation and second is the dialysis. Coming to focus on the transplantations done in 2024 in India, nearly 13,476 transplants was done last year. So we can see that if we compare this with the number of CKD patients in India, so we can say that only 2 to 5 of patients are get transplanted. The rest of 60 to 70% they took dialysis as a renal replacement therapy. Unfortunately, the rest of them are untreated and leads to mortality. So we can see that 60 to 70% of CKD patients are really in huge number compared to the transplant. So focusing on this, Pradhan Mantri National Dialysis Program was started and initiated from the central government, and this is the data of 2023, where annually 317 lakhs of dialysis session was held across the India through a national dialysis program. This is the data of only just dialysis session done through the government segment. Imagine how many number it increase when we add on the corporate dialysis session also. A1 dialysis program at our center. This is the program run by our institute, an initiative from of government of Gujarat, and we have performed over 21 dialysis sessions from the 2010 to October 23. This reflects the scale of the problem, the need for integrated rehabilitation services. At our physiotherapy department, we categorize renal rehabilitation into 3 groups. One, non-dialysis CKD patients, that is stage 3 to 5, but they are on non-dialysis. Second is the dialysis patient, which is stage 5D, and post-transplant patients on immunotherapy. Each category requires a tailored rehabilitation approach. So dialysis patients have severe exercise intolerance due to muscle wasting, anemia, cardiovascular dysfunction, autonomic neuropathy. So hence exercise program must be safe, low impact, and individually tailored. So for this, our protocol includes pre-test consideration, functional and strength assessment, cardiovascular testing, and post-test monitoring. We commonly use 6-minute walk test, chest to stand, hand grip strength, SPPB, cycle, ergometry. So why pre-test consideration is that? So this is time is pre-test consideration timing is very much important. So best is we perform all the tests on the non-dialysis day, and during the dialysis, intradialytic, if save for mild tests, if suppose some mild tests are to be done, then during dialysis day we are performing. Post dialysis is the patient is more on fatigue and hypotension risk, so we do not perform any stress test after post dialysis session. And similarly, monitoring, we do monitor on regular basis on blood pressure, heart rate, oxygen saturation, and fatigue level. And always we screen for contraindications like unstable BP, severe anemia, and cardiac symptoms. Exercise testing, this test helps to assess, for an example, functional test. If you want to evaluate functional endurance, then 6-minute walk test is performed. For strength, sit to stand state is performed. To evaluate for the sarcopenia, we take the help of hand grip, and for frailty, we do help of exercise testing of SPPB. They are simple, safe, and clinically meaningful. Now coming to the approaches of exercise in dialysis patients. So there are 2 main approaches. One is interdialytic exercise, which is between the sessions, and second is interdialytic exercise, that is during the dialysis. Each has its own benefit and limitations. So here 2 distinguished comparisons are being given. So to conclude, I can say interdialytic exercise is better for strength and long-term fitness, and it is low adherence. So intradialytic exercise are better adherence, improve dialysis efficacy, but limited intensity can be given in intradialytic session. So the best approach is combining both, giving inter and intradialytic approaches for the patients. So here is a comparison of dialysis versus normal kidney. So this slide shows that dialysis is only about 10 to 15% as efficient as normal kidney function, which means rehabilitation becomes even more important. To compensate for this, physiological limitations are there. These are the slides which demonstrate few examples of exercise we prescribe, like active leg movements, breathing exercise, therapy and strengthening, weight cuff exercise during the dialysis sessions. These are simple, progressive, customized for each patient. We also have evidence for various studies done in our institute. This is the post-trans rehabilitation. So, patients who have undergone post-transplant, they require careful monitoring due to immunotherapy. Gradual progression of exercise should be there and focus on long-term functional recovery. Rehabilitation here is equally crucial. We do face challenges, so despite all this, several challenges we do face on regular basis. First is the rising ESRD burden, poor functional outcomes, low awareness, lack of structured rehabilitation model, and limited multidisciplinary integration. This is the gap we must address. Future vision is that our future direction should include tele-rehabilitation, home-based programs, AI-driven monitoring, integration into nephrology protocol. It is a must. This will ensure accessibility and scalability. Thank you. And sorry for giving you such a short information about it. My contact details are already there. If you want any extensive knowledge about how to perform exercise during the dialysis, what is the safe mode, and any question is there, you can ask me. You are.
Thank you very much, Dr. Bharat. Indeed, the number of kidney patients are rising so much, and it's high time we start an integrated rehab for them. Now, we want you all to poll here. This is for Dr. Bharat. I want you all to see if you are able to do the poll right now, or are you able to do the poll? Then please do it. This is on even for our virtual participants. Please poll in for Dr. Bharat. Okay, probably what you can do is probably put in your marks or something, and in the end, you can poll for all those participants for whom we have opened for all the speakers. Yeah. Now we go on to the next speaker. This is going to be in neuro rehabilitation. Quality is found in the plasticity of the brain. Measuring functional independence requires sophisticated, standardized tools. Here to guide us is Dr. R. Karthikeyan. He is a professor in PMR and the head at SRM Medical College. We invite you, sir. And one more thing is that all the speakers get about 7 minutes plus 3 minutes, 7 minutes to do their presentation, and another 3 minutes so we can have some discussions. Thank you.
Good morning, all. Thanks, Kaho, Cyril, and Dr. Veena for giving me this opportunity. Am I audible? Right, thank you. So, quality assurance in neuro rehabilitation. Actually, what I'm going to present is basically we had some problems in our department. So it was what to say, just evaluation and a problem-solving venture, which has turned out to be a quality maintenance. So I'll share my personal experience in our ward, other than more into theoretical things. So the Department of PMR in SRM Medical College Hospital, a team of physiatrists, physiotherapists, occupational therapists, SLPs, rehab nurses. We have a team of 40 members. We have inpatient beds of 15 strength. So our scope of services, mainly the neuro rehabilitation. We manage stroke, traumatic brain injury, spinal cord injury. Also the orthopedic post-surgical rehab, pediatric rehab with developmental disorders and cerebral palsy, post-amputation rehabilitation. And we do certain interventions, especially the intra-articular and soft tissue injections. So this is our scope of services. As you all know, the effective quality management is the measurement, assessment, and improvement. So when we venture into that, we had some problems in our department. So through our internal audit with all the stakeholders or members in our team, we came to know that there is pinpoints or the awareness on importance of rehabilitation after acute management, either among the patients within the same hospital or outside hospitals. So once the acute management is over, when the patient is about to get discharged, they will not know where to go, even within our own hospital. So that is one point we came to know that. And management protocols to optimize the hospital stay. Rehab, by default, they say that it is a long stay. But we need to take care of the cost, human resource efficiency. So we were thinking how to optimize the hospital stay. We came to know that the main factors which delays the discharge is mainly the pressure injury management and the tracheostomy care. And outreach awareness programs. When we went to the community, there are a lot of people with complications, especially with the spinal cord injury, saying that after the surgery, they have never had any access with rehab institutions. So we thought, okay, we need to educate people with outreach awareness programs and care after discharge. Rehab is one peculiar department where the patients will be very worried when we say they are getting discharged. In all other departments, they'll be very happy. But in rehab, when we say that you are getting discharged, then they will have all functional abilities. They'll have an accident. They'll undergo the surgery, and it's going to be a new normal life when they go back to the society, which they will be scared. It will be like pushing the patient into the society is just like dragging a small child in the kindergarten school. So we thought that okay, we need to have certain process to make this transition in a very smooth and a comfortable manner. So after that, the care after discharges, there were the patients, they had constraint for reviews. Even to show investigation report, they have to travel a very long time. So travel a long distance and wait for a long time. Thereby, there are a lot of non-compliance, and they go unnoticed after the discharge. And access during their emergencies. There are a lot of occasions where we had complications as autonomic dysreflexia because of bladder obstruction or catheter obstruction, and prescription revision. So these are all the areas where we came to know that they are having difficulties pertaining to our department. Then we said we sat together and formulated certain protocols like how to mitigate this, how to minimize these constraints for the benefit of patients. So awareness on rehabilitation program, which we did in-person counseling for patients within our hospital. So we got the information from the MRD where are the neurosurgery and orthopedics, where the rehab patients are there. We share our the stats, and we go in person, educate, counsel the importance of timely rehab. And even when they go back to their hospital, they say that already we are here for a long time. நாங்கள் ஒரு பிரேக்குக்கு வீட்டுக்கு போயிட்டு வரோம்னு said. So once they go home, it becomes very difficult for them to access our department because they have to call the common operator and to connect us. It's difficult. So we thought that okay, we have one exclusive phone number as rehab call. So straight away they can access our department. And all the discharge summaries our department video consultation QR codes will be printed. So anywhere, wherever they are, there will be 2 QR codes in our discharge summary. One is for the video consultation, one is for our location. So immediately when they scan, the link for our video consultation will come. Immediately they can book the video consultation. So that becomes very easy. The patients are very happy. So SOP for video consultations, again, there should not be any mismatch in their communication or gap in communication. So initially, once the video consultation is done by our therapy team, so they get all the informations. After getting all the information, it comes to me, and we sit together, validate, prognosticate, then we communicate with the family members. The next will be the finance team. They will communicate all the financial part. Is everything is over, then we will share this information to the travel team, where comfortably they will shift the patient to our hospital. So we make sure that there is, in each and every step, there is no lag, and the patient, once if they want to come our Department of PMR at SRM, we make it as a pleasant, good experience. So SOP for video consultations and to receive patients from outside hospitals involving all the stakeholders. In fact, we have our QR codes pasted in the ICUs of other hospitals with their permission. So once they will come home, once they get discharged, they will have a click of the QR code. At some point of time, if they want, immediately they can access. So this really made very easy for us as well as for the patients. Periodical updates, discussions with the referral surgeons. One constraint what the referral surgeon is, once they get discharged and comes to rehab, they feel that the patient has gone away from them. So that really inhibits their referrals. So what we did is, we made a SOP that every 15 days, every week we have team meetings and family meetings. Once the team and family meeting is done, every fortnight we will send a mail to the referred surgeon. So regarding what is the status. So that keeps the referred surgeon very comfortable that they are also included in the rehab process. At some point of time, after 1 month, when the patient goes to the referred surgeon, so when he is able to tell all the happenings of the rehab, the patient is really happy. சார் எல்லாமே தெரியுது உங்களுக்கு, ஸோ ஓகே உங்களுக்கு எல்லாம் நல்லா நான் நடக்கிறேன் சார், எல்லாம் தெரியுமே எனக்கு அப்படின்னு சொல்லிட்டு once the surgeon himself gives the update, the patient feels very happy, and even the surgeon is happy that okay, the patient recognizes the surgeon. So communication, as we involve a lot of stakeholders, communication is very, very important, which really keeps the team with all commitment, and even the patient is very happy. Optimize the duration of hospital stay. So we made this SOPs like session logs for therapy sessions with upskilling sessions for therapists. That is, we make we make a log like when the patient comes in and when goes out, what is exactly happening, how effective the sessions are, and if there is a lag with, because all the therapists will not be of same skills. So what we do is, if someone is lagging, so we do upskilling for those therapists, and we make sure that they give the best possible care. Tracheostomy care training for ward nurses. In neuro rehab, especially with the brain rehabilitation, brain injury like traumatic brain injury or stroke, the longer stay is mainly because of the tracheostomy care. Of course, we have a very good, excellent SLP team. They take care of the tracheostomy part. We have a protocol like when to go for fees, when to go for VFS, spigotting protocols, everything we coordinate. We make sure that there is no waste of time on tracheostomy care. Improving pressure injuries care, this log for position change, nutrition and hydration. So all these things are maintained with periodical internal audits, so that we are optimizing the duration of hospital stay. So this is periodically we do upskilling sessions for all our stakeholders, all the therapists and nurses. This is one very recently we did for nursing care and neuro rehabilitation. Even the therapy team, rehab team from other hospitals participated. So this is we do awareness outreach programs called as SEED. This is SRM education for empowering of persons with disabilities. It's called a SEED program. So every 15 days we make online sessions on important topics to connect with. We have various patient groups. They come on a Zoom meeting. So once we talk about pressure injury, once we talk about all these schemes about the schemes what the central and state governments are giving, it's a medium for us to stay connected with all the people, so that whenever they are in need of help, in between the sessions, they say that, sir, எனக்கு pressure injury இருக்கு, நான் எப்போ உங்க ஹாஸ்பிட்டல் வர்றது. So these programs makes them to feel connected with us, with our department at any point of time. So really it is beneficial for our patients. Care after discharge from the hospitals, again we make video consultations, tele-rehabilitation, very with all ease they can connect with our department. So what are the preliminary changes, improvements, right? There is an increase of 30% of patient referrals from outside hospitals when compared to previous year. A surge of 45% increase in video consultations, but of course no significant change noted in average duration of the hospital stay, because it is multifactorial. Still we are exploring how to optimize it. A significant positive change in pre and post session evaluation scores with our awareness webinar sessions. So these are the preliminary changes which we have noted. So I strongly believe in this slide. This will be the last slide in all my presentations. Any small good effort is going to have a compounding, and definitely it is going to yield a good result. Thank you all.
Thank you very much, Dr. Karthikeyan. I think I resonate to few of the things what you told. You told about discharge in rehab. Actually, there is no discharge for patients in rehab, right? They are with us even as long as possible as a maintenance phase. They are there. I like the idea of which you told about QR code. You putting it in the during patient counseling. In your own hospital, it's okay, but then how did you manage putting it other hospitals? I mean, that's a very genuine question which I was thinking about it.
Actually, it is all about convincing most of the hospital owners.
Okay.
They are members of IMA.
Okay.
So I'm an office bearer in IMA. So we need to say beyond the commercial things, for the benefit of the patients. Sometimes what happens when the surgery, craniectomy or a thrombolysis is done, when it is not being taken care of properly, the patient is not going to accomplish the end result of the surgery, or the definite management is done. So once they come to our hospital, get rehabilitated and go, they come inside with stretcher and they go back by walking, and they are very thankful to the surgeon. Through this proper referral to rehab, the surgical practice is increasing for the surgeon.
Because this is a very good vision actually. And when you told about, again you told about sometimes the surgeons are really thinking like, will I lose my patient? But we have to go that extra mile in writing that report and sending to the physician or the consultant at repeated intervals. So the patient is also confident, and even the surgeon or the physician is also confident. So you are finishing the entire loop, because in quality, when they come, they ask, are you following this integrated practice? If so, where is it documented? So it's very important to follow these points when follow this practice when you are doing taking care of rehab. So friends, kindly go on to the poll if you guys are able to do it. Even my virtual friends who are up there. I kindly call upon Dr. Saril to felicitate Dr. Karthikeyan. And apparently Dr. Karthikeyan was Dr. Saril's professor.
Saril is my good friend. I'm happy to see his growth. Thank you. It's my privilege to receive this from my good friend. Thank you so much.
We go on now to the next speaker. The topic is on geriatric rehab, which is we have more of geriatric population, and that is one of the vision of taking care of this elderly population. As our global population ages, quality in geriatrics means preserving dignity through mobility. To share insights from a unique Indo-Japanese perspective at Sakra World Hospital, I welcome Dr. Ashutosh Naik, who is going to give us insights on quality assurance in geriatric rehab. We invite you, Dr. Ashutosh.
Hello, good afternoon, everybody. My name is Ashutosh. I'm a geriatric physiotherapist from Sakra World Hospital, Bengaluru. So today my topic is quality assurance in geriatric rehabilitation. Is this audible? Yeah. Okay, so globally, we are witnessing a rapid rise in aging population. As per WHO, by 2050, 1 in 6 individuals will be above the age of 60. In India, this transition is even more significant, with the elderly population projected to reach around 347 million, nearly 20% of the total population. This demographic shift is not just about numbers. It reflects a growing need for healthcare systems to focus more on long-term care, rehabilitation, and functional independence. As the aging population increases, we see a parallel rise in life expectancy, but also a higher dependency ratio. This creates a clear shift in healthcare needs from acute episodic care to long-term and rehabilitative care. Importantly, falls remain a major concern. According to WHO, they are the second leading cause of unintentional injury-related deaths worldwide, with older adults being the most vulnerable. There is a high prevalence of chronic conditions such as hypertension, diabetes, osteoarthritis, and cardiovascular diseases. Most importantly, multimorbidity, where an individual has 2 or more conditions, is extremely common, making management more complex. This leads to increased risk of frailty, sarcopenia, and falls, which remain a major cause of injury and mortality. Along with this, we also see progressive disability, functional decline, and rising concerns of cognitive impairment and dementia. Beyond medical conditions, aging significantly impacts functional and psychological well-being. We see a decline in mobility, balance, coordination, and the ability to perform activities of daily living. At the same time, there is a high burden of depression. Ultimately, this leads to a loss of independence and a decline in overall quality of life, which are outcomes that matter most to our patients. Geriatric rehab plays a crucial role in addressing the challenges we just discussed. Firstly, it focuses on restoring function and independence. Through targeted interventions, we help regain mobility, strength, and ability to perform activities of daily living. Extending beyond the individual, geriatric rehab enables safe aging in place. It reduces hospital admission and length of stay, allowing patients to configure with their recovery within their community. Geriatric rehabilitation can be effectively delivered across multiple environments. In medical facilities, we manage acute conditions and provide structured intensive care. In residential settings, rehabilitation supports daily function and promotes independence. At a community level, group-based programs encourage social interaction. This continuum of care ensures that rehabilitation is accessible, patient-centered, and sustained across different stages of recovery. Patient safety is the foundation of geriatric rehab. Beyond preventing falls, features like non-slip floors, proper lighting, and specialized equipments like parallel bars create a secure environment for recovery. Coupled with skilled staffing for safe supervision, these measures empower patients to confidently and progress effectively. Rehab also continues at home where daily life happens. Strategic modifications like grab bars, non-slip floors, and adaptive tools reduce fall risk and lesser caregiver function. Emerging smart technologies further enhance safety through active monitoring. Ultimately, these changes transform the home into a supportive environment that builds patient confidence and independence. Having discussed the impact of geriatric rehab, now we turn into a practical implementation. Designing a center goes beyond physical space. It's about architecting safety, integrating infrastructure, and workflow so the environment itself drives patient outcomes. Designing a geriatric rehab center requires barrier-free environment that eliminates obstacles to for the movement. By integrating essential safety features like handrails, non-slip floors, and emergency systems with supportive tools like parallel bars, we minimize risk. When combined with this skilled supervision, this infrastructure creates an enabling space where the patient feels safe. So, safety in geriatric rehab is a foundation, not an extra. This industrial forester, what you can see on the slide, is adapted for gait training. It provides a safe and secure environment for high-risk patients to mobilize early and confidently. It proves that intelligent adaptation of existing resources can create high-impact, low-cost solutions. Quality rehabilitation isn't just about high-tech tools. It's about engineering safety and confidence into everyday practice. So in this slide, you can see what we are doing in our rehab center for the geriatric patients. In the first video, this is not playing. Okay, video is not playing. Videos is there in that folder. Yeah, final videos. Yeah, in this video, balance training with the industrial fall arrestor. Here we use a fall arrestor system to enable safe and confidence building balance training even in high risk patients. So this is sit to stand training with an albatross trainer. The albatross trainer allows graded sit to stand and standing practice, promoting early mobilization and weight bearing. So this is also one of the safety tool which we use. It's called as safe transfers using powered lifter. This demonstrates how powered lifters facilitate safe, efficient patient transfers while minimizing physical strain on both patient and therapist. This is also one tool which is called as Biodex Balance Master, helpful in assessing static and dynamic balance, including the training. So in the coming slide, what I'm trying to show is that through this example, I would like to highlight an important concept. Innovation in rehabilitation does not always require advanced or expensive technology. Okay, so I think the videos are not playing, but I'll try to explain you through the photo. So what's happening over here is that first we were seeing that two therapists in the first photo, the two therapists are mobilizing the patient with band support. So this reduces the dignity of the patient. Also, it is not that safe. So what we try to do is that we try to innovate a belt called as a safety belt, where in the second photo you can see it is attached to the hip of the patient around the waist, and only one therapist can use this, and it reduces the load on the therapist. It also maintains the dignity of the patient. Quality in geriatric rehab is also coordinated by a multidisciplinary team. At the center of this model is the patient, around whom all care is structured. This integrated approach ensures that care is holistic, coordinated, and outcome driven. To ensure quality, we follow a standardized care pathway. It starts with the comprehensive geriatric assessment followed by an interdisciplinary planning to set patient goals. The journey concludes with the structured transition, including home safety assessments and family education, ensuring a seamless return to community. We assess balance and fall risk using tools like Berg Balance Scale with an MCID of 4 to 7 point improvement and the timed up and go test with an MCID of more than or equal to 13.5 seconds. We also measure muscle strength and endurance via hand grip dynamometry and 6-minute walk test with an MCID value of 25 to 30 meters for 6-minute walk test. We also use validated tools for sarcopenia, nutrition, and cognition. Our primary focus is the MCID value, which ensures results are truly meaningful for the patient. So, also in collaboration with Kaho, we conducted a multidisciplinary geriatric screening camp to move from reactive care to proactive aging. I think this was also mentioned by Dr. Cyril. So I want to this was an integrated model combined medical test and physiotherapy focusing on gait, cognition and emotional health with vision, hearing and speech assessments. By providing real-time expert consultations along music therapy and yoga therapy, we ensured immediate clinical decisions and holistic focus on quality of life. Our screening revealed a concerning hidden burden. Although participants appeared independent, 100% of them showed a high risk of fall, with short physical performance battery scores below 9 and timed up and go times averaging 20 seconds, with MCID value of 13.5 seconds. Additionally, 31% were malnourished. These findings highlight a critical gap. Significant functional and nutritional decline often remains undetected in healthy older adults until an injury occurs. So safety in rehab is, so what I want to show in this slide is that before we were more focusing on reactive care. Even if there is a fall, okay, or if there is some kind of an injury, then only we try to focus on treating the patient. Instead, what we are supposed to try is we have to go for proactive prevention. In the second photo, you can see before something happens, we are trying to secure it. This image reflects just not a camp, but our collective commitment towards delivering safe, effective, and patient-centered care for older adults. As we move forward, it is important to remember that quality and safety are not separate goals. They are foundation of everything we do in geriatric rehabilitation. And as I conclude, I want to tell that quality geriatric rehabilitation is not optional, it is essential. Thank you.
All of you, please give a big round of applause. I know it's nearing lunchtime. That doesn't mean that, you have to keep your spirits on. Dr. Ashutosh, I really like the last slide of yours. We have to move from being reactive, okay, to being more proactive. Thank you very much. And now I would like to call upon all of you, please, on the QR code. I would like to call up on Dr. Prasanna Hegde to felicitate Dr. Ashutosh. Please come up. One small announcement. This is for the on-site people, not for the virtual. The caricature is ready outside, so I advise all of you probably to take turns and go and come. Otherwise, there will be a lot of crowding. So because it's there only till about 3:30, till 3:30, 4 o'clock. So just take turns and go and get the caricature done for yourself. It is near the cafeteria on the 4th floor. Okay. Now going a bit away from some of the clinical specialities, we jump into tech. We move to how the technology and data that drives excellence. It is a privilege to introduce Dr. Sujata Srinivasan from IIT Madras, a R2D2 center whose work is in assistive tech, is redefining what is possible in rehab. A big applause to Dr. Sujata. To connect that, no?
HDMI cable. Thank you. Other way. Na panta? அப்படிதான். Yeah. Sound வருமா? வருமா? I can. Okay. It's exactly noon. So good noon, everyone. Thank you, Dr. Saril, for inviting me for this conference. It's been very nice. I was there for the last two presentations, very eye-opening presentations. It's nice to see rehab being given a lot of importance now. That always makes me very happy. Even though I'm an engineer, I work in assistive and rehab technologies, developing them at IIT Madras. So I'll just take you through quickly. I think I have 15 minutes, right? No, I have 15. Okay, yeah, that's what I was told. So, okay. So the motivation for our work comes from the fact that there are over 30 million people in India alone who are affected by locomotor disability. And if you look at the spectrum of assistive devices, assistive and rehab devices, on the one hand you have very simple devices, very low cost, but they may be too simple to be functional. There's a lot of rejection of such devices. At the other end of the spectrum, you have very sophisticated devices, but many have not even made it from lab to market. And even if they are available, they may not always be suited for Indian conditions, or they are extremely expensive to buy and maintain. So we try to work in the middle space. R2D2 is the TTK Center for Rehabilitation Research and Device Development. And we are trying to develop more functional, high quality, and affordable assistive devices that use appropriate technology. Like the previous speaker mentioned, don't always need high technology. Things don't have to be high tech for them to be useful. So that's the space that we work in. And using this approach, an interdisciplinary approach, we have so far translated 7 devices to the market. We have here NeoMotion. That was the first spin-off from R2D2. You'll see later Siddharth talking about the NeoBolt and other products from NeoMotion. So I'll talk a little bit about, I'll show you what we do. So some of the challenges we need to address in this space. One, you need an appropriate device. In India, we don't have many indigenously developed appropriate devices for our population. And I always use eyeglasses as my example because, I can't function without my eyeglasses, but I don't think of myself as disabled because it's been normalized to the point. The usage has been normalized to the point where you don't think of yourself as having a disability. So why shouldn't it be the case with other assistive devices? So it has to be appropriate, it has to be customizable. If it makes you functional, then we have to work towards removing the stigma of using the assistive device. It has to be affordable. Given our situation where insurance doesn't cover assistive devices or rehab, that's a given. And many people lose their ability to earn a living after disability. So that's another challenge. Awareness is very poor. I think I heard that again, making doctors, surgeons aware of the importance of rehabilitation and how it actually enhances the work that they do. That's missing, and awareness is missing about what kind of devices are available. So that's a big challenge as well. And access. How do you get customized devices? It's not like a Lenskart. You can't have companies like Lenskart doing assistive devices because it's a much smaller market, and but the devices have to be very customized. And that's one problem that NeoMotion has cracked very nicely, because being in Chennai, they're able to service, they're able to provide customized solutions anywhere in India or the world. And ultimately, it's about acceptance. Once the user accepts their condition and realizes that the AT is actually helping them become more independent, it also increases awareness all around, and the stigma starts dissipating. That's the goal. That's the eventual goal. So assistive devices have to look nice also. It should be something they are proud to own. So here I'll just share quickly a few of the things that we have worked on. So one of the first things that we worked on is a standing wheelchair. So why standing? I think those who work in rehab understand very well that if you're in the seated position all the time, if you're unable to stand, then you're at risk of developing secondary health problems like poor blood circulation or life-threatening pressure sores. Standing also has functional benefits because that's the way our world is designed. If we were all wheelchair users, we wouldn't need such high ceilings. So it's also a function of the environment that we live in, and so standing provides some benefits there. But even as therapy, standing is required for many people to manage their spasticity, to maintain some bone health, etc. And here is a video that demonstrates how difficult it is normally for a person to stand.
Day-to-day aspects of mobility demand effort and assistance, often leaving paraplegics and their caregivers overwhelmed. Hours of sitting in a wheelchair can cause secondary health problems to the user, like poor blood circulation and reduced bone density, among other issues.
Minor injury people definitely need a physiotherapy 2 days in a week. So it will avoid our big sore under. So our leg get spasm otherwise.
So it's a challenging task. So with NeoMotion, we developed a wheelchair, which is a manual wheelchair with motorized standing. It's called the Neo Stand, and it offers benefits like you can stop at intermediate positions. That was something therapists told us is very important. So, you don't have just a binary sit and stand position. It provides ability to move when you're in a semi-standing position. And it's also like a compact form factor. So this is Neo Stand.
They say it's like a forgotten memory, a whisper from a time before, an echo you can't quite grasp, but whose absence you feel every day. It has no form, no weight, no user manual, but you know it's there. The yearning to rise, to meet the world eye to eye, to experience that shift in perspective, that surge of independence. This isn't a machine, it's an extension, a bridge between who you are and who you long to be. A chance to rediscover a forgotten feeling, a forgotten you. With a touch, a world awakens. The chance to experience life on your own terms, a reminder of your boundless spirit. The feeling, you won't need words to describe it. Every sunrise, every hello, every adventure becomes a testament to its power. This is more than mobility, it's possibility. It's the chance to write your own story, a story with a standing start. This is freedom, redefined. You stand.
I will let Siddharth talk about the other NeoMotion products, but I just wanted to put it out there. So, yeah. So that's, NeoMotion is now a fairly established company in the AT space in India. They're doing very well at reaching all parts of India with their customized solutions. The journey, like we saw from hospitalization to be able to use assistive technology, requires, there are many steps along that journey. Assistive technologies can enable independence, but to get there, you first need the rehabilitation. And again, because of the scarcity of healthcare, trained healthcare professionals and access, we are trying to develop some technology that can help fill that gap. And this is work, the rehab work is something that we are doing with CMC Vellore. So as you know, for rehab, the challenges are the poor PMR workforce to patient ratio, again, lack of awareness of the value of it, lack of the financial resources, insurance, all that, and lack of access. And so these were, we don't have devices, we don't have many devices that are suited to the Indian context. You saw some really sophisticated devices in the other presentation, but most are not accessible to, say, a therapy clinic, a small therapy clinic or even smaller hospitals. So that's where we came up with Pluto, which is a plug-and-train robot for hand rehabilitation. So I will just mute this so I can. Yeah, so everything fits inside a box. So a therapist can actually carry it with them on a two-wheeler. It can be tabletop mounted or mounted on a height adjustable stand. The therapy can go to the patient. So therapy can start as early as possible in the bedside itself. Instead of the patient having to go to the robot can go to the patient. We focus on training the hand movements because that's often a neglected part in post-stroke rehabilitation. So you have different hand movements as well as functional movements of the hand for performing activities of daily living. And the therapist can gather data so they can see progress, which will keep the patient motivated. And the training is gamified. The training is gamified with performance adaptive games so that the even home rehabilitation is possible. And they can use this. We've actually done a home study with this robot. So these performance adaptive games they change their difficulty depending on how well the patient is doing. So in the trial phase, we did it across 8 centers in India with more than 1,000 users. This is the work that we are doing with CMC Vellore. And our latest startup, Thrive, is taking this forward. And we just got the ISO 13485 compliance for the device because it's a medical device, and we will be launching it. The manufacturing has started. We'll be launching it in about a month or so. But yeah, you get a preview. So, thank you. These are some of the research outcomes. We, of course, do, with the development, we are also looking at during the development and post-development also we focus on research. So I will, we also last year launched a lightweight wheelchair, but I will skip that. I wanted to just show you that at in terms of quality. So at R2D2 we focus on the R&D. So we've developed test fixtures that can test wheelchairs to ISO standards, prosthetics to ISO standards. So we have developed these capabilities in-house so that the devices that we are developing are built to international quality standards. And we realize that developing technology is alone not enough. So the National Center for Assistive Health Technologies, which is located in the IIT Madras Research Park, right next to us. So that is a visitor center. It's an experience zone, and I'll just show you the video that will. So we have training sessions for therapists, we have training sessions for wheelchair users. Almost every month we have a batch of wheelchair users. We've created these architectural barrier zones like grass and the potholes and all that, so that people learn how to navigate that on a wheelchair. Our peer trainers, so we have a very multidisciplinary team of occupational therapists, physiotherapists, social workers, as well as expert wheelchair users who help train the other users. And so they also take them out on community visits so that they learn how to navigate the community in which we live in. So this is located, and I would invite all of you, if you have an opportunity, it's a visitor center, it's open 9:30 to 6 all working days. So please do visit. We have our website that you can take a look at also. I would just like to thank all our collaborators for their support, whether it's through funding or through other kinds of support, as well as our industry partners, our startups and other partners. This is my team over the years. Not all of them could be accommodated, but at various things. I tell them they are the people who make me look good when I come and present at different places. Thank you for your time, and thank you for this opportunity to share our work.
Thank you, ma'am. It was wonderful. And I guess you are under your leadership, this is all happening, and I think much more advances in technology in rehab is due, which will happen in near future. Thank you very much, ma'am.
Thank you.
I now call upon Dr. Komal Agarwal to felicitate Sujata, ma'am. Moving forward, we dive into women's health, one of the most neglected sessions which require a huge importance and attention. Women's health through the life cycle from prenatal to postpartum demands a specialized quality assurance lens. To discuss this vital role and this niche area, please welcome Dr. Shalini Nair. She's a physiotherapy consultant and specialized in obstetrics and gynecology at Cloud9 Hospitals, Bangalore. Please.
Good afternoon, everyone. This is Dr. Shalini, physiotherapist from Cloud9 Hospital, Old Airport Road branch, Bangalore. So I'm here to talk about the quality assurance in OBG rehabilitation. Just a brief about the organization that I work with. We are total at 44 centers pan-India, and these are our values, which is predominantly focused on the quality of patient care. OBG rehab, if I have to discuss, we divide into two basic categories, that is OBS and GYN. Let's dive deep into each of these categories. Antenatal rehab is something which I guess all the women's health physiotherapists practice across all the centers. But how do we make it better is what I'm going to talk today. So when we talk about one-on-one session, we are giving patients different forms to select so that it becomes patient-centric. So we have one-on-one in-person or one-on-one video consultation so that they take a call on it, because being pregnant, sometimes they find it difficult to come to the rehab centers to do their exercises. So getting a proper assessment done virtually, documenting it in the DX app, making sure the prescription is sent with the right exercises, and even giving up them a follow-up date makes a lot of difference in their quality journey. And also the new quality improvement project that we have taken up is our group online session that you can see, the antenatal online fitness program, because everybody wants an online class these days. So we've made it a point that we follow all the ethics while practicing that also. We have a physio who does the class, then we have a buddy physio who is there just to take care of the alignments of the patient. And before even enrolling them into the class, it's very important that we assess them based on the two major criteria, that is their cardiac endurance and the strength. And then we decide whether they go into the basic, intermediate or pro level. So this is something that we follow. Coming to labor support, this was a previous year quality project because movement is the key to vaginal birth, and who better than a physiotherapist present inside the labor room can do this. So that was the major reason why this was given so much importance. And also the major reason being WHO threshold for C-section is just 10 to 15%, but in India we are right now at 21.5%. So I think this is a project that we all should do in all the multi-specialty hospitals to make sure that with the correct labor support, when the woman is supported with good physical, emotional and informational support by the right qualified person, the outcome measures, that is the types of deliveries or how long she'll be in the active labor, the episiotomy rates, the epidural rates, even the instrumentally assisted delivery rates can come down to a larger extent. And of course, there are a lot of advances in this. Right now, we have TENS from Ellie, Mama TENS. A lot of TENS machines are there. We have Swiss ball, peanut ball, cup stool to help us with this process. Immediate postnatal rehab, something again which is followed everywhere. But again, the key to this is early mobilization, which I think we've been discussing from the first slide. So as early as 6 to 12 hours, if we start mobilizing our patient, it does make a lot of difference in their postpartum journey recovery. Quality-wise, we have a TAT of 24 hours. So the patient is assessed and reassessed within 24 hours, and that data is monthly maintained. Being an OBG physio, we also have our scope spread across breastfeeding journey. So we have our interdisciplinary team with the lactation support person. So they tell us if there is any patient who is engorged. Breast engorgement is a very physiological thing that happens post-delivery. So as a physiotherapist, we help them with the ultrasound therapy. So that's why the equipment cleaning checklist is also very important quality standards that we are maintaining. And of course, once they have discharged from the hospital, the follow-up is the most crucial thing. That's what we tell them and send, which is majorly for our diastasis recti rehab. So this was one area where we were not getting a lot of patients previously. People were not turning up for a follow-up. But a simple change like adding one more leaflet in our fitness book, which gave a description, virtual description or a pictorial description of how DR looks like. And when we explained it to the mother, and a single line added in the discharge summary that please do follow up after 2 weeks with your OBG physiotherapist for your DR check, made a lot of difference. We had almost 60% increase in our referral rates coming to us. And this could reduce a lot of mummy pooch issues, which a lot of people have. So DR rehab was one of the good quality improvement project where we saw instant results immediately. PFM rehabilitation, now this is a very big umbrella with a lot of topics under it, but to name few, vaginismus, PFM dysfunction, perineal trauma, episiotomy, scar, massages, these are some things that we do. Now this is the area where quality and patient safety matters the lot, because a very sensitive and crucial area where patient has to be taken care holistically. It's just not the OBG rehab that plays an important role over here. So you have to understand every aspect of the patient and take care accordingly. First thing is the consent. most important thing which we think we forget a lot of times, but the most important crucial part is consent. How many members are allowed in the treatment room? That makes a difference here. Biomedical waste segregation, a very important thing that plays a very important role when you're treating a PFM dysfunction case, because you would end up using gloves, sometimes dry needling, even dilators, vaginal cones. So there are a lot of objects which we use which needs proper sterilization. So having your connect with CSSD department is equally important. We try our level best to use one-time users, that is the patient buys them and they use it for themselves. But when equipments like vaginal cones and anal cones are used, electrodes are used, it's best to get a proper sterilization done, and that is something that we follow. So again, your equipment cleaning checklist should be a major category when you're dealing with a PFM rehabilitation case. Forums to discuss about patient care. So again, everything dives into one simple topic, that we have to have a multidisciplinary team approach. So we do conduct our perinatal meetings, where we have our meetings with the gynacs, obstetrician, gynacs, and the pediatrician, so that we get a complete care of what has been happening. Pediatricians also included, because we follow golden hour of breastfeeding. So we make sure that the breastfeeding is started within 1 hour after the birth. So during that labor support, even that becomes an important category where we could help the mother with. So this is all discussed in our perinatal meeting, a departmental meeting which helps us, and half yearly we do try to submit a quality improvement project data, so that in the clinical audits we are taken care of. And we have an internal audit team called as REACH, which helps us to make sure that our quality standards are maintained. To sum it all up, scope of OBG service, very huge, cannot be shortened up in 7 minutes. But what I can tell is there are so many things happening at different stages of women's life. And a physiotherapist is going to be an important part in each stage of the life, starting right from PCOS, dysmenorrhea, from the menstrual cycle to TTC, trying to conceive, pregnancy, post-pregnancy, menopausal, and all kind of PFM abnormalities. Although there are a lot of advances, but the basic nuances, your assessment skills have to be good to take the chance of advancement technology into the treatment. So the quality will improve when we have more skilled OBG professionals getting into the field and making sure that the assessment skills are up to the mark. Thank you.
Thank you, Dr. Shalini. Rightly spoken. As you told, the scope is much beyond antenatal and postnatal. As you told, even today, the menstruating children, the girls, perimenopause, menopause, postmenopause, all these things are big issues to handle. And when you told about PFM, how much awareness are we really doing? Because we do get number of patients, but then not so much. Probably the awareness is required more. Yes. Yeah, at this point of time, I think we have only been speaking. Anybody wants to ask any questions from the audience, at least to the speakers who are around? Yeah.
Chemicals to clean it, disinfect it, and sterilize it.
And then they give it in a sealed package to us, so that we get to know that this is being done.
So usually we'll have to check with the original equipment manufacturer, the OEM, whether it is ETO friendly or not. I'm not sure. There might be. It's very specific to the company that manufactures it.
I had another question, but that was to Ashutosh.
We'll get him right.
Get to him.
Next. Yes, we will organize from Kaho side. We can do that program for. Yes. Now we go on to the next speaker. The next talk is on onco rehabilitation. Sorry, I call up Dr. Saril to felicitate Dr. Shalini. going to the next session on Onco Rehab. Onco Rehabilitation is about survivorship, ensuring that life after cancer is lived to its fullest. To discuss quality assurance in speech, swallow, and functional recovery, we have of Kaho Global Rehab Forum. We welcome you, Dr. Prasanna.
I should look good. Yes, thanks. Thank you. Very good afternoon to everyone, and vanakkam to Chennai. I wanted to say I was a RCB fan and I want Chennai to come up on the table, but I thought it will be, I don't know how it will be taken, but anyways I have said it. And to those who are hearing me for the first time, I would like to introduce myself as a case study of Dr. Saril. Actually, I don't know why I'm here, and said the same thing last time. I'm here today is because I practice, or I'm an integral part of Onco Rehabilitation. I have not done anything in quality projects yet, but I'm trained in Lean Six Sigma program, which is a quality, assurance program or certification. So why Dr. Saril wants me in the team is because he can make me a case capsule so that others. So he's chosen a moldable person in my field, that is speech language pathology. I'm not sure if there is any SLP here, right? There are no SLPs here. So that speaks for itself. So he's taken me from my field and he wants me to propagate all the quality assurance aspects into my field, right? So with that, I'm going to look at quality assurance in onco rehabilitation in my understanding in the very early stages, the baby steps. Probably it's not even born for me. Learning outcomes, again, this is the assignment given by Dr. Saril and team to talk about, but like I said, I've not done projects to give you data from what I've done, but real world experience, it's all about having consensus, right? It's all about understanding what the other person knows and does not know, and telling them that what you know and what you don't know, and having an understanding about what we don't know and what we don't even know that we don't know. Those are all the aspects that we look at. Here is a video which beautifully depicts, does the video play? Which beautifully depicts about communication or understanding the perspective of a person. Okay, I can share it. That's okay, no problem. So it was that video where one Neil guy would be telling the other Neil guy that there is a crocodile in the river, but the one which is standing far, it is saying, no, it is not crocodile, it's log. You must have seen in YouTube, right? So the third one comes and again says it's log. So what are we doing is that there is no communication or understanding of perspective into our consideration. Same thing happens. A lot of people talk about communication in quality. If you talk about dysphagia, ITC is one of the standard. If there are clinical nutritionists or SLPs, they will understand that if I say khichdi here, it should be same khichdi in North India as well, for the safety purpose, for the safety of the patients. So this is my real world experience. I work at a tertiary cancer care center, which is KRHCG hospital. It is one of the 26 centers run by HCG, and I think ours is the only center which has 97% utilization, service utilization. Others are not even coming close to 2 digits numbers yet. So why am I talking quality when my own hospitals are lagging behind? But that is the challenge that I'm going to take up as the person who want to look at quality in these kind of settings. So in our hospital, operational insights are that there are multiple departments, and I'm proud to be a part of a onco rehabilitation team, which I have not seen in India yet, in terms of the extensive communication or extensive interdisciplinary work that we do. We have rehab MDCs every Thursday that is done. We have speech and swallow, psycho-oncologist, physiotherapist, dental rehabilitative oncologist, yoga, naturopathy, clinical nutritionist, integrative oncologist, and support groups, which is site specific again. So these are all the people who are going to sit together and plan treatment. So I differentiate multidisciplinary with interdisciplinary because we think that multidisciplinary is that it's an alternative treatment possible, but interdisciplinary or transdisciplinary, you're going to facilitate somebody else's work. There is no alternate treatment for swallowing or dysphagia. Okay, there are treatments from a deglutology perspective. A physiotherapist will work on the aspects of the neck movement, the shoulder movement, and the chest health, or the lungs capacity to take out or be dry, correct? These are all the facilitatory aspects. So that's why we work in tandem for the same goal. If somebody is talking about nutrition, if you're only feeding a person, it's going to be difficult. If they are not doing exercise, where is the uptake? So if you're only talking about how much calories are going in, but not counting the number of steps, it's going to be difficult for us. So clinical excellence right now is specialty clinics. We are still establishing specialty clinics in terms of service delivery. One of the in-short news came up as saying that the capsaicin is actually helping the anti-inflammatory ability of a person post any inflammation or fighting ability, which is going to be a natural way of fighting inflammations. But post-radiation, the patients are not able to, post-radiation therapy, patients are not able to have spices at all. There is 100% intolerance to spices. I have not seen any patient who received radiation therapy for head and neck cancers tell me after 3 months that they are able to have their spicy biryanis or chicken curries or anything. So are we denying the natural ability to heal is something that we look at. And what is the number of referrals that we get is around 7% in our hospital. It's still the first spice rehabilitation clinic in the world is getting 7% right now because I have not marketed myself yet. So those are all the aspects that I'm going to introspect on myself and constantly improve on how I can reach out to people who may or may not know. So data-driven quality is still in desktop. It's not yet come out. I am sitting on it and thinking that it will fly by itself and go and get published. But there are logistic issues for us in terms of the clinical load that we have, in terms of time management, in terms of resource management, in terms of the ability to think innovatively. Right now, like I said, Dr. Cyril's pet project right now is going to give results, year on year. Every time I'm called for some talks, it's going to be different. So forward thinking, yes, we made some protocols that are not taken from the Western world. We are looking at culturally adapting or culturally developing from the scratch. It's not adaptation or translation. It is working from the beginning in terms of what the patients need. It is on a day-to-day basis. So ideal case scenario, I will get hold of a patient 10 days prior to surgery, which is probably 5% in all the patient load that we have. Usually they get admitted just a day prior or in the evening, and then they are rolled into OT, and then I will be able to see only in the ICU probably when they are awake. Right, so all these things are just an example of how we have to develop from the scratch in terms of what we do. Then comes whether we are doing it in right or not, or how consistently we are doing it. So we always believe that for me, quality means compassion, commitment, and consistency. These are the three things that we look at in terms of delivering any services for us. So this goes till 2 years beyond treatment, because some of the problems stay on, for at least 5 years or even beyond. There are late radiation changes that happens, fibrosis, there can be recurrence. Again, problem is going to be, multiplied. This is one of the specific, site-specific protocol, which includes all the departments. That is for total glossectomy with a CA tongue, advanced CA tongue, where what are the department's role in during the timeline of their stay from POD -3 to post chemoradiation therapy. So these are some things that we can develop locally and see if it can be workable for us. You may not have dedicated specialists because capacity building is difficult. And I also believe that uniform healthcare starts with uniform education. We don't have uniform education. There are 62 colleges in India which give speech and hearing education, and all the syllabus is different. No national institute is talking to other private bodies or smaller colleges to streamline those things. They're still in competition mode. If there is a competition mode, then there is no possibility of quality improvement. We can only collaborate and improve. quality. So I would like to cut open all the aspects of definition and purposes of aspects which I think is going to be a hurdle for me. The definition of quality control is that in the context of onco-rehabilitation, quality assurance refers to systematic process, if it exists, designed to ensure by whom, who designed it, that the services provided, service available or not, we don't know that. There are 178 hospitals registered under NCG, that is National Cancer Grid, and I don't think more than 10 hospitals have all the rehab specialists. Majorly you will find physiotherapists or clinical nutritionists who are overburdened. The nutritionist to patient ratio is too much, or physiotherapist to patient is too much. And meet established where? We don't know that. Standards of excellence is something that we need to look at minutely and start to understand that whether it really works from us, to talk about high terminologies is something we need to look at. And we'll go to dissecting the purpose of things. The first one is ensuring, yes. Yes, how many minutes more? We have only 1 minute. 1 minute, okay. Yeah, thank you. Ensuring high standard of care. Now we have to prioritize on ensuring there is care, ensuring there is standard, ensuring that it can be high, and ensuring that it can be ensured. These are all the aspects that we need to step by step look at. The next one is replicability of care. If it's success, preventability if it is a failure. This is something you need to look at. That is what is going to improve the patient outcomes. We need to understand patient outcomes for a physician is different, for a rehabilitation specialist is different, and patient is different. Enhancing patient satisfaction. See, outcome is different, satisfaction is different. Patient comes with swallowing problem, goes back with swallowing problem. What are we doing? Best way to commit to ask, what do you want? What do you expect from the healthcare? Accountability, transparency. Which one comes first? Who's going to bell the cat about not referring timely? Who's going to ask the difficult question? Identifying and addressing issues. My issue may not be issue for you. How do I deal with it? I need to understand whether you are able to understand what my perspective are. It may not be about I don't care. It may be different perspective. Professional development. A question to you all. What will the frog in a well grow old to be? Quickly, I don't have much time. No, it will become a well so that it can hold another frog in it. That is how the growth happens. It's about box, right? If you cannot get out of the well, at least attract more frogs so that the well becomes beautiful. Compliance and regulations. So we have gray regulations, so we have gray compliance, right? It's like she loves me not. She loves me not. That kind of thing. So you cannot deal with this kind of aspect. So we need addressing every level. So with this last sentence, increasing the chance of QIP success is only by minimizing external dependence. That means if finance is involved in my QIP, it can be rejected at the management level. So try and do something on your own. Best quality improvement project is on self. I think that will give us the best outcomes for patients rather than looking at high value projects where manpower and finances are important. At least to begin with. Thank you very much.
Thank you, Dr. Prasanna, for putting some light on the unsolved and lot of gaps which is existing in the current clinical practice. Thank you. I call upon Dr. Rimsha to please felicitate Dr. Prasanna. Dear all, we now break for lunch, and we have exactly 35 minutes for lunch because we have much more power packed things in the afternoon. We have quiz, We have music therapy, and yoga. So kindly finish your lunch and come back here in about 35 minutes. The food is going to be in the 4th floor at the cafeteria. So please assemble back. Now it is 12:45 by about 1:15, 1:20. Thank you. Also, because it's in the 4th floor only near the caricature, have your lunch and simultaneously get your caricature also done. Good afternoon, everyone. So, welcome all of you back to this post-lunch session. So, we are going to start with community-based rehabilitation. The true test of quality is scalability. How do we maintain rehab excellence when we leave the hospital walls? Dr. Cherian, who is a community-based occupational therapist from Herbertpur Christian Hospital, Dehradun, he joins us to discuss quality assurance in the community. I welcome you, Dr. Nikhil. Also, very good afternoon to my virtual participants. We are starting the session on community-based rehabilitation, quality assurance in that.
Hello, good afternoon. Good afternoon, everyone. I hope you guys had a good lunch, and I really missed Tamil Nadu biryani. I used to be here. Coming from Dehradun, yeah, we really missed that a lot. So today I'll be talking more about quality assurance in community-based rehab. My name is Nikhil, and I'm a community-based occupational therapist, and I work in Herbertpur Christian Hospital, which is in Dehradun. So we have titled, before we go to the quality assurance, we will be talking a little bit about the model of our service. So we have titled the model of practice at HCH as challenging barriers, facilitating belonging, which encapsulates the essence of community-based rehabilitation services in our target areas. The CBR program at Herbertpur started in 2002 as a father's pursuit to meet his son's rehabilitative needs. At that time, attitudinal, environmental, communication barriers, all these things rendered people with disability as an invisible group within their society itself. In this context, the program steadily has grown into a vibrant space that not only addresses these barriers, but also fosters belonging, enabling people with disability to be recognized, included, and valued within their own communities. Based in Dehradun district, the rehabilitative focus of the program has been to reach families of children with developmental disabilities and families of adults with neurological impairments. The program reaches out to 2 blocks of Dehradun district and the towns of bordering states of Himachal and Uttar Pradesh. The model of the program has been aligned with the CBR matrix that has been laid out by WHO, which focuses on the domains of health, education, social, livelihood, and empowerment. Now, this slide gives a glimpse of the service provision pathway of our program. The services have evolved in order to meet the needs of the people with disabilities across all life stages. Every person with disability undergoes a comprehensive multidisciplinary assessment and is placed under one of the services that best fits their needs. These services are also supported by active community mobilization, which includes awareness and advocacy, training of community-based rehabilitation workers, and establishing local networks. Now, These are three strategies that have made this model of service provision a sustainable one for 2 decades. There are 6 community-based disability resource centers that enables children from respective communities to avail the mentioned disability-specific services in their own villages. Residential spaces, school buildings, or any public spaces available have been rented and modified so that it is conducive for rehabilitation. Often a therapist alone run model is not feasible in the rural communities. Therefore, the CBR workers from the local community and parents have been empowered to be active caregivers and service providers. Therefore, we have equipped them with RCI registered trainings, which is something called CBID, and a non-formal capacity building opportunities also. Thirdly, in order to ensure that resources are mobilized, partnerships have been established with government and non-governmental agencies. In our journey of 20 years, the program has evolved significantly in a community that initially had no access to disability services. This is a context where stigma and reliance on traditional healing practices still prevail, and retaining rehabilitation professionals also pose a formidable challenge. Presently, the program is a RCI registered training center delivering comprehensive and affordable rehabilitation services. Local Disabled People Group, or DPG, have emerged who actively advocate for their rights and foster community empowerment. Furthermore, Government of Uttarakhand has entrusted our organization with responsibility of managing a state-level government-run home for destitute women. Okay, now let's come for protocols that ensure quality and safety, and it has been categorized into 3. The legal protocols allow that the program is being evaluated by the government under the RPWD Act and ensures safety and confidentiality of the beneficiaries through parental consents or intact policies. Our service protocol follow a referral mechanism to avoid reliance on non-scientific practices. This also ensures that all the children and families receive equitable services, enhancing both personal, individual or personal progress and parental participation. The quality protocols ensure executing services in an accessible and efficient manner through capacity building and monthly reporting. There are 6 key performance indicators that are used to measure outcomes of the program. How many persons with disabilities are receiving the services? What are the functional statuses of children with developmental disabilities? How much are the parents participating in our program? Their engagement in their communities. Are people with disabilities have access to entitlements, and are they properly trained to their fullest of capacity? This is a story that captures various services a person with disability can possibly receive across life stages, aligning with the CBR matrix. This is Shahrukh. Shahrukh is now 26. Shahrukh was identified by the CBR program at the age of 11 after a spinal cord injury left him bedridden and without access to any rehabilitation. Through the program, he received treatment, returned to school with accommodations, completed his completed his education via NIOS, and underwent computer training. He supported his widowed mother through poultry rearing, which was also provided by the program. Then he also later went to establish a CAC center in his society itself, which he used his NeoMotion wheelchairs to give services door to door to people with disabilities. Later, last year, his community work led to an election which he won as a block developmental Development Committee member. And today, Shahrukh continues to advocate for disability rights and serve his community. Yeah, thank you. So we have few future goals also to see. We want to move forward from to a co-design and a co-production model. And we want to have a balance between need-based and evidence-based model of service that is customized to the people. We also want to have parents championed through capacity building programs. We also want avenues for educational and vocational mainstreaming, and possibly partnering in implementing of governmental policies. Thank you. Any questions?
Thank you, Dr. Nikhil. I think there are a lot of lots of vision forward for you guys to accomplish, and all the best for that. I now call upon Dr. Jeba to felicitate. Yeah, anybody has any questions? Yeah, please.
From your CBR, have anybody who is like beneficiary come to your organization as a therapist or counselor or anything? Has there been a reversal of role from their side also?
Yes,
because
yes.
of your program?
So there are we don't work just with children with disabilities. We target more into families, and among those families there are mothers who are more interested in working with us. So when we talk about CBR workers, they are not just any random people from the local, but they are also mothers who have children with disabilities, who have been trained through and then they do RCI registered course, and then they come.
Yeah, but to add to it, so we have visited your place and we are quite impressed with that. We have been to another project.
No, wait.
Please give a big applause. These all young budding professionals, they have a way long to go.
Before this goes off, let's just do it.
Okay. Now we are going to have the quiz competition. Now this is open for both on-site as well as our colleagues who are there online who have joined with us. For this, I welcome Dr. Komal Agarwal. She is going to run this Kahoot session of quiz for all of us. I kindly invite you.
Hello everyone. So welcome, and today we are putting up our knowledge on rehab quality and safety to the test. Whether you are here in the room or joining us virtually, we are going to have some friendly competition. So please join us. For this, what you need to do is go to your browser on your phone or laptop and type in kahoot.it. Can we all log in quickly? For those who are here present in the room, you can also just scan the QR code on the screen if you are here. And I request you all to please enter your real name so that we know whom to congratulate at the end. I see 2 people in. Great to have you. Let us wait for few of us to join. Requesting all our online participants also to participate. And let us know if there are any issues. The online team, if you're having any trouble seeing the pin, it will stay at the bottom of the screen throughout the session. So don't worry, you can stay connected. So the game pin is 2003080. I repeat, it's 2003080. Shall we wait for 2 more minutes? Those who win, we have some exciting prizes for the first, second, and third prize winners. So let's try to participate. Yeah. We have 26 participants. Nice. Everybody here is available on it? Anybody having trouble? No? Great. "44 participants. Yes. We'll start the game as soon as we have 50 participants in this. Okay. So we are ready? Okay. It's a game which is the fastest finger first. So be very attentive on the question and answer as fast as you can. So the first question is, which indicator is most sensitive for detecting early safety issues in rehab settings? The options are length of stay, near miss reporting, patient satisfaction, or mortality rate. No answers yet? Yes, we just have 2 seconds. Okay. We move on to the next question. Dr. Satish Babu is on the top. Let's move to the next question. Let's try to be fast in answering the questions. Which model best explains error causation in healthcare systems? Maslow's hierarchy, Donabedian model, Swiss cheese model, or PDSA cycle? Seven seconds left. Nobody answered. Internet is slow, okay. Okay. We'll just try one more question and see how it goes, okay? Otherwise, we'll take it to the next. In rehabilitation, patient-centered care primarily means reducing cost, aligning care with patient goals and preferences, faster discharge, or following therapist goals strictly. Is the internet still slow? 17 of them have answered correctly. Dr. Satish Babu. Next question. Which of the following is a process indicator? Fall rate, time to initiate rehabilitation post-surgery, readmission rate, or functional independence measure gain? 10 more seconds. Very good. 38 answers. We'll see who's on the score. Okay, let's move on. In rehab, which is considered a sentinel event? Fall resulting in fracture, patient fall with no injury, delayed session, and mild fatigue after exercise. Five more seconds. Not opening. We'll wait for a while. Yeah.
The good thing is nobody got to answer. We all lose.
Next question, which is the best example of patient safety culture? Focusing only on outcomes, punishing staff for errors, ignoring minor errors, and encouraging incident reporting without blame. We've got 3 answers already. Great. Okay, so the right answer is encouraging incident reporting without blame. Moving on. Which tool is most appropriate for continuous quality improvement? Histogram, SWOT analysis, fishbone diagram, or PDSA cycle? Five more seconds. Great, all have answered. Suri on the top. Not here, online participant. Nice. In infection control within rehab units, the most effective measure is isolation rooms only, PPE usage occasionally, hand hygiene compliance, or antibiotics. Great. So the right answer is hand hygiene compliance. I'm sure we all follow this, right? Good competition. Which scenario best represents a never event in rehabilitation? Delayed therapy session, wrong patient receiving therapy, patient dissatisfaction, or mild post-exercise soreness? Great. Wrong patient receiving therapy. That's right. R. Subramanian. Which is the most appropriate method to analyze complex system failures? Checklist, root cause analysis, patient feedback, or random audits? Root cause analysis. Good. So we are halfway through. 10 more questions. Shall we go ahead? Which concept ensures right care at the right time by the right team? Equity, effectiveness, appropriateness, or efficiency? Good participation. Appropriateness is the right answer. Parvati, new competitor in the team. Which is the most overlooked safety risk in rehab settings? This is a very tricky question. Do focus on this. Falls, transition of care, infection, or equipment failure. Oh, that's quick. 19 participants have given the right answer. It's transition of care. What we say is handover or handoff. Suri. In a multidisciplinary rehab team, lack of communication primarily affects outcome, finance, structure, or process. Lack of communication, what does it affect? Okay, we've received all the answers. Process is the answer, dear team. Okay. Let's see the next question. Which step in 5S ensures long-term adherence to improvements? Shine, sustain, sort, standardize. Long-term adherence to improvements. It's a very easy question. Okay, sustain. Moving on. Which distinguishes clinical audit from research? Audit generates new knowledge. Audit avoids patient data. Audit compares practice against standards, and audit requires randomization. Yes, audit compares practice against standards. Good, keep it up. Which of the following is not one of the 5S principles? Sort, sustain, simplify, or standardize? Simplify. Good job. Which of the following is an example of an outcome indicator in rehabilitation? Mind it, it's outcome indicator. Improvement in FIM score, time spent per therapy session, staff to patient ratio, and number of incident reports filed. Twenty-seven answers correctly given. Navya is on the top. What is the primary purpose of root cause analysis in rehab safety? to assign blame to individuals, to identify system factors, to reduce treatment costs, or to evaluate patient satisfaction. Okay. Which type of audit is conducted in real time during patient care? Retrospective audit, prospective audit, concurrent audit, or external audit? Concurrent, yes. Concurrent audit. So now we're moving on to the last question. Benedict. Game changer. So this is the last question for today. Which intervention best reduces falls in geriatric rehab? I think we all attended a session. Reducing therapy sessions, increasing therapy intensity only, bed rest, or environmental modification and balance training. Oh, great. Everybody loved the session, I guess. So thank you. Are we ready for the results now? Yes, eagerly. Yeah, waiting. Okay. Third prize, Suri. Second prize, Parvati. And the first prize, Benedict. Do we have any of them here? Benedict, Parvati, or Suri? All are here. Wow. I request Benedict, Parvati, and Suri, ma'am, please come forward if you're all here. May I please invite Dr. Saril to come forward and give away the gifts? Later, we'll take a photo, yes. Please join us. Thank you so much. Let us all have a big round of applause for the winners. Thank you so much. Thank you all for participating. I hope you all enjoyed the session. Thank you very much.
Thank you so much, ma'am, for the wonderful quiz. Now I would like to call Dr. Saril for facilitating Dr. Komal Agarwal, ma'am. Thank you, ma'am. Thank you so much. Now I like to call Dr. Saril for facilitating Dr. Veena Nambiar, ma'am. Thank you, ma'am. Thank you so much, ma'am. Thank you, sir.
Yeah. Good afternoon, all. We really thank all of you for gathering online, on-site, virtual, all the different platforms. Today's highlight of the day, as we conceptualize this entire journey, is the next event, which is music therapy. What comes to your mind when you say music therapy? Okay. What do you think is music therapy? Relaxation. What else? Listening to music. So we get music, put it next to the patient in ICU, or put it next on the bed, patient's bed, keep a earphone. That's music therapy, right? That comes to your mind. If that is the understanding, we are the perfect audience for the next session. Let us explore what exactly is music therapy or music as therapy. I repeat, music as therapy. So we should understand this, and this is something that we have really tried and tested in Bangalore campus. And who else to really take us through this session other than Dr. Purva Sampath. She is an expert who is trained from USA for music therapy and performing arts. So she has an institute which runs, and she has a lot of people who are actually doing internship with her. We did try a few other music therapists, but somehow we found that her expertise is at another level actually. So let's have a formal kind of a presentation, but after the lunch, after the heavy meals, I think this is the best way to do that. So all of you who said relaxation, brace your seats. It may not be that. So we are going to enjoy it actually. Yes, exactly. Over to you, Dr. Purva, one of my good friends. Thank you.
2 minutes. I just want
And all the virtual people also, we remind you that please be connected. If you have any problems, please let us know on the group. Thank you.
Good afternoon, everyone. Can you hear me without the microphone? Yes. Okay. I'm guessing we need the mic for the ones online. Okay, so whenever we're doing music, I might step away. I hope that that everyone joining us online does not mind. How is everyone doing this afternoon? Wow. I think the biryani hit the spot really well. One more time. How is everyone this afternoon? Okay. Very honestly, little tired, sleepy. Who's feeling dehydrated from this heat? No one? Okay. I constantly feel dehydrated. Nice. Who's thinking about what they have to do after the conference is done or the events are done today and you have to go home? Who's thinking about stuff that you have to do? I'm thinking. I have to catch a train after this. Who's thinking about something at work from last week that you still haven't finished? Maybe someone sent you a reminder. How many of you are thinking about all of the other things that you could be doing this afternoon? Okay. I'm glad to see that. To start off with, I am Purva Sampath. I am a board-certified music therapist, and I specialize in neurologic music therapy, which means my foundation and approach to music therapy is based in neuroscience. Very quickly, music therapy is the clinical and the evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a trained and credentialed professional. Now, this is a very common definition that we use, but in reality, I think the definition of music therapy and how it's practiced is very culturally relevant. One of the things that music therapy or some of the areas that music therapy can help address is cognition, movement, speech, communication and socialization, sensory and emotional processing as well as regulation. And of course, in a neuro rehab setting, music therapy can also help in building community or breaking the monotonous way in which a patient or a family, the caregivers that are around, experience music therapy. So as we do music together, I will talk about a few case studies that I have also encountered in the last 2 years in neuro rehab. So very simple. All instructions are going to be on the screen. What I want you to do is follow the instructions and play along. Okay, can we all just stand up wherever we're sitting? Stand up, can we stretch? Okay, twist. Crack your knuckles, get ready to use your hands. Please don't punch the person next to you while doing it. Okay, all right, great. Take a seat. Pick a song. What song shall we do today? Okay, I have one person picking Staying Alive. Any other picks from the options available to you? Instrumental. How many for A? Show of hands. How many for B? Show of hands. How many for C? Show of hands. How many for D? Show of hands. Okay, it looks like C seems to have the most. Give me a second. I'm just connecting the audio. Okay. We can all hear the music. Can we turn up the volume a little bit? Okay. Everyone can hear the music clear enough? Okay, great. There are 4 movements, okay? So when I say tap, it's tap on your lap, clap, shake. This is something we also call this a clap that we use for individuals who are hearing impaired, but also individuals who have auditory sensitivities. So sometimes we call them jazz hands, or we call them the silent clap. Okay? So tap, clap, shake, snap. Okay, can we try that? Tap, clap, shake, and snap. Great. Okay, we're going to start from the beginning. Ready? 4, 3, 2, 1, and tap. Tap, tap. Wait, don't speed up yet. It'll get more complicated. Simple enough? Okay. Tap, clap, tap. Okay, a lot of musicians in this room seems like. Keep going, tap and clap, clap. Get ready. 1, 2, 3, and tap, clap, shake, and clap. Tap, clap, shake, clap. Tap. One more time. Clap, shake, clap. Now tap, clap, clap, shake, and snap. Tap, clap, clap, and snap. Tap. Oh. Okay, now we're going to try the same thing, but we're going to do it in double time. Ready? First was only tapping. Okay? We'll do that. Ready? 1, 2, 3. Start, clap, clap, shake, snap. Clap, 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 clap. Clap, clap. Ready to complicate it further? We'll try the last one, but at this speed. Ready? Tap, clap, clap, shake, snap, tap. Thank you. Can we, there we go. Okay, how many of you are feeling more awake than when we started? Okay, nice. Good morning, everyone. Why do you think, or what do you think happened in the last 2 to 3 minutes in our brains while we did this?
Hand-eye coordination.
Hand-eye coordination, amazing. What else?
Concentration.
Concentration, okay, yes. Alertness, lovely.
Repetition.
Repetition, yes. What else?
You have to sustain the movement of the arm.
Sustaining. Neuroplasticity. Oh, I love presenting to other therapists. Lovely, thank you. Neuroplasticity, what else?
Working memory.
Working memory, absolutely. Who said that? Amazing, thank you. Yes, working memory. What else? Planning, okay. What else?
Sequencing.
Motor planning, sequencing, quick response, yes.
It's a group therapy also. It's group.
It was easy for a large number of people to participate, absolutely. Anything else?
The visual.
Yeah, the visual cues also played a role, and we'll talk about why very soon. But why anyone found it really difficult to do this, or anyone felt discouraged to do this? Anyone that took maybe 1 or 2 rounds to get into it? I made mistakes. I took a few rounds to get into it, especially post lunch. Okay, but did that discourage you from wanting to participate? Why?
Peer pressure to adherence.
Peer pressure to adherence, yes, in this context, but in a context that is not academic pressured, why do you think it was easy to engage in this, irrespective of the fact that we're all probably going through very, very different things, or we all have a million things on our mind right now, but why was it easy for us to participate?
Sense of instant gratification.
How many of you felt, whenever you got it right, how many of you felt a little sense of, yes, I got it? Anyone? No one? I feel that way. Every time I play an instrument and I play the right chord or I sing the right note, it is extremely gratifying for me, right? And let's understand why that happens. Music is one of the only activities that research has proven time and time and again, which engages both the left hemisphere, the right hemisphere, the brainstem, as well as our vagal nerve. That's where the polyvagal theory is born out of. But it also strengthens the corpus callosum, which is the band of nerves that connect both the hemispheres. So we know today that this idea of anything creative or artistic is predominantly in which hemisphere? Left? Right hemisphere. And the idea that anything analytical or anything that requires cognitive effort is in the left hemisphere is something that has been disproven, because we now understand that when we engage in whatever we call creative, right, be it music, be it dance, be it art, be it drama, any form of expression, we are engaging multiple areas in our brains that aren't restricted to just hemispheres. So today we know that there isn't a section in our brain that lights up for music, but instead it has global impact on the brain. So what you just did right now was essentially like a quick 2-minute workout for your brain, right? Now, when we add singing to it, that's going to be a full HIIT workout for the brain. And this is something that happens irrespective of your neurodivergence or irrespective of neurodegenerative disorders, or in the case of neuro rehab, also acquired neurological disorders. So when we use rhythm because we call it the bedrock of music therapy, or the foundation of anything that we do in music therapy. And we call it that foundation because of the way the rhythm is processed in our brains. So in neuro rehab, when we have patients that are struggling with initiation of movement, or we have patients who are struggling with even or uneven movements, or patients that are struggling with a range of movement, we use rhythm through music as a way to be able to reroute movement through the auditory cortex. When we listen to a very strong rhythm, right, it enters our ears, goes and gets processed in our auditory cortex, and because the motor cortex is right next to the auditory cortex, every time there is a really strong rhythm in the environment, we end up moving to it. We end up tapping our foot, we end up clapping, we end up bobbing our heads, and this does not engage our cognition. It is a very natural response to a external rhythm. So when we use this in the context of music therapy, music that or rhythm that can help match the movements of our patients will actually help in enhancing their even movements or symmetrical movements. It can help in enhancing the range of movement, especially when we use musical instruments, which I will take out shortly. Sorry. And I will share this with all of you for our next activity. But rhythm helps not just with motor planning, it also helps with speech planning. We just spoke about this. Rhythm also drives movement when the motor strip struggles with initiation. So ideal spaces to use rhythm as a way to help with movement will be in gait training. It can be in upper body movements or even fine motor movements. Often playing instruments can also help develop different fine motor as well as gross motor movements in the upper half. Consistent repetitive movement also helps with the nervous system regulation. So one of the biggest reasons why I get referrals in the neuro rehab space is not only because a patient might be interested in music therapy, or because a patient might be a musician and therefore be pre-exposed to music in their lives, but it is also patients who are not responding to other forms of therapy, or patients who have reached a certain point in their recovery journey where either they withdraw and they don't want to participate, or they're unable to participate. Another area are disorders of consciousness. So when a patient is non-responsive to other forms of sensory stimulation, music can be one of the things that can help elicit an initial response from them. Rhythm engages cognition through executive function skills. So somebody over there said working memory. Talk about things like attention. We usually only talk about sustained attention, right? When we say attention, we mean, okay, how long is somebody able to focus on a single task? But one of the really amazing things that music does is it also employs alternating attention, switching attention, as well as, I'm forgetting the fourth one right now, but sustaining, alternative, switching, and focusing on multiple tasks at the same time, right? So what we were doing right now, one was tap and clap, we did just tapping, we did tap, clap, shake. So you were integrating multiple cues that were coming from a visual point. It was coming in auditorily. It was also coming in through looking at the people around you and interacting with them, right? So in what we just did, the reason you felt more alert was because your prefrontal cortex, where a lot of our cognitive tasks are processed, was engaged the entire time, right? It's not that once you started tapping, you zoned out, because the movements kept changing. So it is a great way to engage other forms of attention as a way to build on sustained attention during recovery. Music can also bring up very strong memories, right? Someone that chose Staying Alive here, would you like to share the memory that you have associated with it? Or what does that song make you feel like when you listen to it?
Made me think about the office.
So is that what kind of emotion does that elicit for you when you think about The Office?
Just pure comedy and all.
So it puts you in a space or in an emotional state where you're more willing to engage than you would be if you weren't feeling like it, right? So when we talk about music therapy, we do not prescribe music. Music therapy is not prescriptive. There is no research yet that proves certain ragas can heal, right? And while it's the association that the brain has built with a certain style of music, which is very powerful in music therapy settings, music therapy in itself is not about the kind of music, it's about the elements of music like rhythm, melody, pitch, harmony, dynamics, so how loud or slow, how fast, how loud or soft, how fast or slow a piece of music is. Okay, now that we know a little bit about rhythm for recovery, why don't we try some singing for speech? Yes? Yes?
Yes.
Thank you. Shall I pick a song? What seems to be the easiest? We Shall Overcome? Yeah, everybody knows that song. Even if you don't know the song, it's easy enough to pick it up. Shall we try that? Anyone vehemently opposing We Shall Overcome? No? Okay. In the meantime, can we please this bag is filled with music instruments. Please be gentle with them and please return them after the session because my clients will miss them. Please pass the bag around, and I don't think I have enough for everyone in the room, but I have quite a few. So please pick an instrument and pass the bag around.
For all those who are present here, in case if you have missed the caricature, it's only till 3:30, so please take time in between, go and he is available actually. How many of you got the caricatures? I think we have a wonderful team. I think few people have missed out. Please go ahead with that. None of us know how to do that later. So please don't tell us to do it for you. It's a wonderful facility, so please make use of it, okay? Up to till 3:30 you have time. Thank you. And I'm really sorry for the online participants. We will not be able to draw virtually. Thank you.
Okay. All right. So small change to these instructions. I will tell you the words. Please remember them. It's we shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe that we shall overcome someday. Hindi version is हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन. ओ मन में है विश्वास, पूरा है विश्वास, हम. Okay? But what I will ask you to do is keep rhythm if you can, either with your instrument or through tapping your foot, tapping on your lap, anything that feels natural for you. Okay? I will give everyone a minute to select their instruments, and then we'll get started. Okay, everyone has an instrument? Yes? Okay, can I hear your instrument? Okay, try that either on the chair next to you without breaking it, or on, maybe not the wall. Chair. Chair is better. Okay. Okay, everybody has it. Usually if there's just one stick, you'll find another, well, maybe now you won't, but use that stick either on your lap or on the chair next to you. Just be careful that you don't hurt yourself. Okay? Ready? Will you join me in the first time only, or do you want me to sing once and then you'll join?
Sing once.
We shall overcome. We shall overcome. We shall overcome someday. Oh, deep in my heart, I do believe that we shall overcome someday. Okay? Simple enough? 4, 3, 2, start. We shall overcome. We shall overcome. We shall overcome someday. Oh, deep in my heart, I do believe that we shall overcome someday. Okay? We walk hand in hand. We walk hand in hand. We walk hand in hand. We walk hand in hand someday. Oh, deep in my heart, I do believe we walk hand in hand one day. Hindi. हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन। ओ मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। Okay, nice. So we'll stick with 2 verses. We shall overcome in English and hum honge kamyab in Hindi. Okay. Now I'm dividing the large choir into 2 parts. Okay. We have part A. We have part B. Okay. When I say A, whatever role you have to play in the choir is what you're going to do. When I say B, whatever role you have been assigned is what you're going to do. Okay, so we'll start off very simple. We'll start with A. A, you will sing the first 2 lines. That is, we shall overcome, we shall overcome, we shall overcome someday. Is what part A will sing. Part B will sing. I do believe that. Okay, ready? Simple enough. Everybody can continue playing their instruments for this round. 1, 2, 3, part A. We shall overcome. We shall overcome. We shall overcome someday. Oh, deep in my heart, I do believe shall overcome, we shall overcome someday. Deep in my heart, I do believe we shall overcome someday. Pay attention, huh? You can't skip a beat. Ready? 1, 2, 3, stop. We shall overcome. B. We shall overcome. C. Oh, we shall overcome. K. Oh, deep in my heart, I do believe we shall overcome. Okay, simple enough. Now, we're going to make the instruments a part of it, okay? So when you're singing, each group, A or B, when you're singing, you can't play the instrument. When you're playing the instrument, you can't sing. Okay? So, same, we shall overcome, we shall overcome, we shall overcome someday. Deep in my heart, I do believe we shall overcome someday. So, when A is singing, you are the band for them. So, your rhythm has to be on point so that they don't skip a beat. Similarly, A, when you are singing, sorry, when B is singing, A, you are the band. So, you have to make sure that rhythm is on point. Ready? 1, 2, 3, start. Now, for our final performance. Final performance for today. We shall overcome. Second, we shall overcome, we shall overcome. We shall overcome someday, everyone sings. Okay? Deep in my heart, oh, I do believe. Only that last section over there. So from our friend who loves The Office and behind, that row and onwards. Oh, deep in my heart, I do believe is right at the back. We shall overcome some days, all of us. Okay? Remember? We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe. Everybody, we shall overcome someday. I won't add instruments to it right now. We'll try just this first, then we'll see how we feel. Ready? 1, 2, 3, start. We shall overcome. We shall overcome. We shall overcome someday. Ready? I can't hear. That we shall overcome someday. Hindi. हम होंगे कामयाब, हम होंगे कामयाब. English. We shall overcome someday. Hindi. मन में है विश्वास. English. I do believe. Hindi. Together, हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन. ओ मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन. हम होंगे कामयाब एक दिन. Please give yourselves a big round of applause. You were a brilliant choir. What did we do just now? We not only sang, but we also continued to engage with rhythm, right? So our brain was not only processing rhythm as an external auditory stimuli, but we were also using different areas of the brain that is related to speech and comprehension. How many of you understood the words that you were singing? Right? How many of you found it easy to sing this song once we did it a couple of times? Okay, great. So singing uses different pathways compared to speaking, right? But having said that, singing is also a great way to help relearn speech or build that new neural pathway in the brain to access speech when they have had either a stroke or a TBI. So a lot of speech and language recovery in music therapy happens through what we call TIMP, which is in neurologic music therapy, we call it therapeutic instrument playing. But it also happens through MIT, which is something that we share with speech and language pathologists, where we use melodic intonation therapy, or we use the way that melody is processed in the brain to mimic melodies in speech, right? Why do you think we all have accents when we speak English? Any guesses? Why do we have accents when we speak English? You're mimicking.
Mother tongue influence.
You're mimicking, or you're saying the words in the way that you would say it in your primary language, which for most of us is not English, right? The way that I speak English is very similar to the way that I would speak Tamil at home. But at the same time, the way that an American would speak English would be very different because they don't have that bilingual context in their brain to be able to access different syllables. So very similarly, when we sing, we're able to access different sounds, different syllables, as well as different ways of engaging the motor movement of speech, right? And singing also helps us with comprehension. What was the language comprehension that we did here? Any guesses? When we switched between languages, right? So you were still understanding, but at the same time, it was a larger cognitive effort that took place because you were translating, but you were also paying attention to see what you had to do when, right? Rhythm and melody processing in the brain also helps with speech planning. So sometimes when a patient is not ready to start engaging physically in speech yet, this can be a great way, right? Auditory rhythmic stimulation, as well as even just being able to hum along to songs, or doing something like, we shall over. Even if you didn't say it out loud, you finish the phrase in your head. And this is because, again, of the need for the brain to finish a melodic phrase, right? So eliciting responses using singing, especially when we're looking at speech-based responses, is very effective when we use music, right? If I say, twinkle, twinkle, little star, how I wonder, I didn't even have to tell you, hey, I want you to fill in the blanks, or I want you to finish the song. It also helps in building both lung capacity as well as consistent breathing patterns. So when we train as singers, one of the first things that we are taught is how to breathe before we even start using our voices. So a lot of the times when a patient is recovering and they're struggling with speech, it might not just be language production or language comprehension. It could also be breath, right? Their voice is too soft because either they've gotten used to shallow breathing, or they're not able to figure out how much air to hold in, when to breathe in, and when to be able to breathe out, which affects their the legibility in what they are saying. So singing is a great way to build that capacity and consistency in breathing patterns. Again, familiar songs can help trigger speech and therefore strengthen language processing and comprehension. So We Shall Overcome is a song that we've all heard, right? So if I use a familiar song, like I just did with Twinkle Twinkle Little Star, it can elicit a response without requiring the kind of cognitive effort that goes into learning a new piece of music. This is why we advocate for patient or client preferred music. Of course, it strengthens our neuroplasticity as well as our overall brain function. especially the cognitive aspects that are required for communication. And that brings me to the end of my presentation. Thank you so much for having me, and I'm happy to take any questions if we have the time.
Thank you, ma'am, for the wonderful music therapy. It was relaxing, refreshing, and truly uplifting. We are grateful for your time and effort. Now I would like to call Dr. Sahir for felicitating Dr. Purva Sampath, ma'am. Thank you, ma'am.
A gentle reminder, those music instruments are not the gifts, so please return it.
Please put it, if we can pass the bag back this way, where you can drop your music instruments.
And that said, let me remind the sweet gift that we all have for you is the caricatures. Only till 3:30, only half an hour left. So if you want to do one more, no problem. If you want your AP view, posterior anterior view, anything, please go ahead with the caricature. All right. And I also would welcome the Frontier Lifeline hospital team also. If anybody wants to do it, it's a token of appreciation from our side. I would suggest all of you to please go ahead and do the caricatures and tell your friends also. Okay, just half an hour more left, and I request the photographer also to probably capture the photographs in the 4th floor, the caricature. Syria, thank you. And over to Dr. Jabba for the last portion of today, which we call as Rehab Tech Talk. Now, this is a very interesting segment which we dedicate for Make in India. So we call it as Make Way for Make in India. Thank you. Over to Dr. Jabba.
Good afternoon, ladies and gentlemen. I'm Jeba Shakila. I'm a co-committee member of Kaho Rehab Forum, and also I'm a chief physiotherapist from Meenakshi Hospital, Tanjavur. So it's a very great session we had. So that's a gentle reminder. So now it's time to vote again for the speakers. So we have the QR code on display for you. So now it's time for you to vote for the most impactful speaker of the day.
I hope all of you remember the speakers and their wonderful topics. So all the speakers of the day, please vote now. You can access through the QR code. And please select your most favorite speaker's name. That's all you have to do. And there are 1 or 2 questions we would like to hear from you, your feedback, and that's about it actually. And we would give away the prize for them in the valedictory function. Please go ahead. And special request to all the online participants also. I'll again put it up this in the online forum. Thank you.
Varun Kumar. Just go back to the previous slide, sir. The one with the picture. Just stay there. No. All right. So you can keep pulling. Anyway, let me introduce the theme of the main CAHOCON, because the pre-con theme has been talked a couple of times, the heart of quality rehab excellence in action. So let me put you the main theme for the main CAHOCON conference. So that is tech, touch, and trust. So the new healthcare code. So there is a lot of emphasis in integration of technology, human touch, and trust in healthcare delivery. And we at Kaho Rehab Forum also, we emphasize a lot on technology integration. As you would have seen in the introductory presentation by Dr. Cyril in the morning, from our forum, we have had many webinar series on technology. So we strongly believe, from the rehabilitation side, we have to inculcate a lot of technology into our field. So let us move into it. And the theme for this tech talk is Make Way for Make in India. So this is more than just a slogan. It represents a powerful movement towards self-reliance, accessibility, and affordability in healthcare technology. So India is actually a rapidly emerging hub for frugal innovation, where high-quality solutions are being developed so that it could reach for every common individual in our ethos. So from robotics to virtual reality to mobility solutions and adaptive design, those technologies are redefining how rehabilitation is actually delivered to the Indian setup. So these innovators are not just doctors we have, or the engineers, or the entrepreneurs. They are problem solvers addressing the real human needs. So without much lagging, let me get into the session. So let me take the privilege of inviting to begin with the first speaker, Dr. Varun Kumar Ramkumar, representing Nambikai Rehabilitation Devices, NE Private Limited, Chennai. He is an MBBS graduate from Madurai Medical College who has co-founded the startup Nambikai Rehabilitation Devices. It is currently inculcated at IIT Madras Research Park. He'll be presenting a digital knee report card, an innovative approach to tracking and enhancing knee rehabilitation outcomes. So we welcome to the stage.
Slide change.
It's pre-recorded. Yeah, after that 1 minute you can take it to add on. We can be there.
Hi panelists, my name is Varun and I'm the co-founder of Nambikai Rehabilitation Devices. We're here to give you AI-driven monitoring to knee rehabilitation. Knee health is currently subjective and unreliable. The current measures we take are static and are done using expensive equipment. A great proportion of the surgeries we conduct are unnecessary. So what's the solution to this? We at Nambikai are here to clear your doubts. We're giving you the world's first AI-driven knee report card using our digital twin technology. We're doing this at the fraction of the cost of an MRI in the size of a pulse oximeter. Through this, we ensure that we give you dynamic insights. We give you the ability to actually decide if you need surgery or not. 2, 3, in the future, we'll be able to predict the risk of disease should you not take any action in terms of corrective measures. And finally, like I said, we're doing this to ensure there's greater access to individuals by making it at the fraction of the cost of the current assessments. So how do we do this? We do this through our patented 3-step process, which is our custom-built IMUs, which are placed at specific bony landmarks. All this is then fed into our specific AI algorithm, and any doctor or patient can get these insights at the comfort of their home. So now let me run you through the process through a demo video.
Okay, fine. Okay, let me just. Inside
We did get the video.
Okay, fine. Show the image.
The sensor is placed on the bony prominence of the tibial tuberosity and the assessment leg is flexed to 15 degrees using the provided wedge. 4 control tugs are applied, each held for 3 seconds with a 12-second gap between tugs.
So guys, hi everyone. Thank you for giving me your time. I just take a small thing and yeah. So thank you Saril sir for inviting me. Saril sir has been my mentor and thank you for giving me the stage. A quick intro. So we're at IIT Madras and we're building something called a knee rehabilitation tool. So I'm an MBBS graduate. I am from Madurai Medical College and right now what we're trying to do is to quantify knee health in a simple manner. The device is the size of a pulse oximeter and it goes and you go place it on the tibial tuberosity. In addition to this, we also can place it using a specific bioadhesive tape at specific bony landmarks. This is what you're seeing right now is a person performing a test. He's characteristically at 30 degrees, which is something similar to something called a Lachman test. So in that Lachman test, this is the degree that you see. Now, in the device that can measure this forward movement is something called the KT1000, which is available in 2 places in India. One of them is Ramachandra. So this is the only place where you can see this. So now they do this at the size of half a table, that device, and it's not easily portable, and you get inaccurate readings. Which is where we come in, not just to give you basic what anyone can do. We're trying to innovate and change the ball game. We're not trying to make that cheaper solution wherein everyone can do it. No one's going to copy us even in Germany, China, Japan, because what we're doing is we're simulating this technology to visualize each structure inside this knee. That is, I'm not just going to tell you how much this is going to move. I'm going one step further and saying what are the structures in the knee which is contributing to this. Now, the one problem you face is every doctor that was saying, yes, there's doctor-patient shortage. Now, when you go to a doctor and he says surgery, how many of you are confident that, yes, I need surgery? How do you say that I need surgery or not? What is that thing? There's that confidence, trust, everything. So here, one of the parameters we're trying to solve is, how do I quantifiably assess the capacity of the surrounding structures to compensate? So that is one of the things. I'll just let the video play across.
This measures the anterior displacement of knee movement. The subject performs 3 squats with each squat lasting 10 seconds. This helps measure the flexion and extension range of the knee joint. The subject is then asked to recreate the same movement and the difference in the knee flexion angles between the 2 attempts is calculated as proprioception error, indicating joint position sense. The final parameter is Geno Varum valgus. This is assessed by measuring the Q angle using 3 landmarks, the ASIS, center of patella, and the tibial tuberosity. Lines are drawn between these points to calculate the Q angle, which indicates knee alignment and whether the knee shows varus or valgus deviation.
At the end of all this, you get the first AI drill.
So what we're trying to do here is take your attention to this. So right now, I'm sorry the screen is very blurred, but what we're trying to do is, what you can get is range of motion, proprioception, Geno Varum. They can just give you the value. What they can't give you are the insights on those values, what do you derive from. When I say proprioception, there's something called the jerk velocity. All this is important because there's neurocognitive control, which is all important in the future of rehabilitation, which is neuroprosthetics, which is where we are trying to innovate and take this forward. Similarly, when I say the Lachman test, all you can get is the anterior tibial translation. But in addition to that, we can measure the ligament elasticity, we can measure the damping ratio, the endpoint. All these are characteristics which are critical for a thing. And in the next phase, we also intend to take in parameters such as crepitus, for example, your knee joint. So once you understand how the knee joint is doing and you are able to analyze the sound about the knee, for example, how the crepitus is doing. For example, when an old person walks, there's something called varus thrust. That is all in the next phase. So initially, we came out with a quantitative knee report card to say, hey, this is why you're doing. Let's say an old person comes with a problem, an ACL person comes with a problem. The first point of contact, instead of an MRI, can be this device. So which is where we came up with this knee report card.
Knee report card. To give you insights on parameters that far transcend the current crude measures.
Environment with strong data protection standard, digital knee health assessment platform designed to support doctors in diagnosing and managing knee conditions more efficiently. The platform provides a secure healthcare environment with strong data protection standards, ensuring that patient medical information is stored and managed safely.
So this is just a UI UX of how we do it. So our model is based on a subscription-based model, wherein we give the device at a fixed cost of we've fixed it around 50,000, and the doctor charges a test per basis to each of the clients. That is, the doctor charges around 1,000, and we charge around a subscription model of 500 per test. So totally there are around 30 tests, and it's charged as a bundle of 30 tests to each patient, and they can take it for and as and when they want, they can subscribe and get more tests. So that's the business model we have, and this is just a basic video of our UI UX here we have. So now let me run you through our team. So our team is supported by Mr. Arul from Germany. So Mr. Arul is the founder of Helix Sense Germany, so he's one of the pioneers in this field. Dr. Kannan sir has been kind enough to support us. Saril sir is also one of our mentors on this. Professor Mani sir is from IIT Madras, who's been involved. Sujata ma'am has also advised us earlier. Now in addition to this, we have these are advisors from Mr. Venki and Mr. Selvan. So they have been on the financial team advising us. So going forward, the small take-home message I would like you to take from this is we've developed an innovative device, which is the size of a pulse oximeter, that can be placed on your knee to give you insights about how your knee is doing in form of a knee report card. So the next time you have a pain, you go take a Nambike knee report. The next time you're 40 years old, there are a lot of people who are progressing to osteoarthritis and are not able to understand where they're placed. This device can come in. Not just in our market, this device transcends our market and goes one step forward into the insurance sector, where they don't have metrics to quantitatively assess themselves. So abroad, this plays a huge paradigm in terms of giving metrics to help assess, because abroad quality is not an option, it is a necessity. Thank you.
Is there any questions from the audience? Okay, thank you, Doctor, for an insightful presentation on leveraging digital tools for precise assessment and rehabilitation. So now let me invite the speaker, Dr. Varun. Please stay with us and on the dais, and let me invite Dr. Abhinash to give away a small memento to him. Profile first, the PPT laboratory. Thank you, gentlemen. So now let's have the next speaker for the day. We have Mr. Siddharth Daga. He is a co-founder of Neo Motion, an assistive technology and company dedicated to improving mobility and independence for persons with disabilities. His work focuses on developing customized wheelchair solutions tailored to individual needs, and his contributions include motorized wheelchair add-ons and adaptive seating systems. He'll be speaking about customized mobility solutions, focusing on empowering individuals with tailored assistive devices. Stage is yours.
Hello all, my name is Siddharth Daga and I'm here to talk about customized mobility solutions for persons with locomotor disability and the elderly so that they can live a life of independence and convenience. The problem that we are wanting to solve, we identified that a lot of wheelchair users are confined to their rooms, confined to their homes, unable to go outside, and as a result they are invisible in society and unable to do the various activities that other people are able to do with ease. We saw that most of the wheelchairs that are used by individuals are of a one-size-fits-all category. So it's a standard-sized wheelchair which is used by every single person, whether they are a child, an elderly, or a person with spinal cord injury, or a person with amputee. Everybody is forced to use the same kind of wheelchair, and it results in a lot of other side effects and a lot of other issues. There are also outdoor mobility solutions which require assistance all the time, and as a result they cannot be used independently to go outdoors. These these wheelchairs which are standard made and not made according to a particular person leads to a lot of postural issues in the patient. So for example, a large seat width can lead to scoliosis. It can be one of the reasons for scoliosis, where you have a deformed spine and a deformed body. Also, various other postural issues can happen because of incorrect seat widths, incorrect seat depths, and also incorrect footrest heights. And as a result, you have a very visible and a very permanent deformity in your body. There are various kinds of wheelchairs, such as active wheelchairs, powered wheelchairs, pediatric wheelchairs for children, for washroom usage, for general mobility, general movement of surgical wheelchairs, and also sports wheelchairs for your day-to-day para-athletes who use for their sports. Most of the customizations primarily fall in two categories. One is the measurement related customization, which is based on the measurements, anatomy of the person. And secondly, the functional requirements of the wheelchair. What is the wheelchair going to be used for? For indoor mobility, for outdoor mobility, for sports, and various other things. So broadly, all the customizations would fall under these two categories. And as a result, you have multiple kinds of wheelchairs which cater to both body measurements, the body requirements, and also for the customized utility needs. For example, manual wheelchairs, electric wheelchairs, your joystick operated wheelchairs. Then you have standing wheelchairs which allow a user to stand, and it can be for clinical reasons, it can also be for functional reasons. And also you have pediatric wheelchairs for children, which not only provide size adjustments as the child is growing, but also provide tilt and space options for various activities during the day, such as feeding, such as resting, and other such activities. This is a video of just showing a video of how a customized wheelchair can actually impact the life of an individual. Here you see a manual customized wheelchair which is made according to the body measurements of the individual, and as a result it's a very compact wheelchair. It is able to move in very cramped spaces such as supermarkets, such as narrow aisles in such markets. Also, when the person wants to go outside, they can use attachment systems like this which convert your wheelchair into a mobility scooter, and you can go to various places like the gym, like a workplace, and various other things. And then once you're completed with your work, you're again able to attach the mobility device and then convert your wheelchair into an outward scooter, and now you can travel from one place to another. These are made durable such that it can be used in rugged terrains, on speed breakers, on potholes. These are also now allowed in public transport systems like metro trains, so that a person can use this to go far off distances and pursue their activities. It can be used to go to colleges, it can be used to go to a place of work, it can be used to go meet some friends, and for various other activities. And once you reach your destination, you can again very easily detach the front part, detach the motorized part, and then convert it back to a manual wheelchair. And you can see how a customized wheelchair is very easily maneuvered inside cramped spaces, in elevators, in malls, and various other places. Most of these mobility devices, in fact every mobility devices, has to go through various compliance parameters. There is a standard called as the ISO 7176, which drafts all the compliance related tests that every wheelchair manufacturer needs to conform to. Just showing a video on what these tests would entail. There is something called as a double drum test, which requires a wheelchair to be moved on two drums like this to test the durability of the wheelchair. And then the second test is called a drop test, where you put a load that simulates the load of a user, and then the wheelchair is dropped from certain heights, and this runs as a cycle for as many number of cycles that you require. So these are various tests that come under the ISO 7176 standards to qualify wheelchairs for their safety. So customized mobility solutions can really enhance the lifestyle of a user. They can use this for livelihood, they can use this to go out, they can be used by farmers so that they can pursue their activities, by students, by army veterans, police officers, to pursue livelihood opportunities, to pursue para sports opportunities and win medals for the country. Thank you so much, thank you. I'd just like to add... Hello all, my name is Siddharth Daga, and I'm here to talk about customized mobility solutions for persons with...
So I just want to add, it actually came up while I was sitting and listening to all the presentations. I think close to 8-9 years back when we were working on this, on wheelchairs, we spent a lot of time at CMC Vellore. And one of the statements I heard there was, we spent, and this was from rehab professionals, occupational therapists and physiotherapists, PMR professionals, that we spend so much time with the patients and, we help them reach a stage where they get back to society. But then a bad wheelchair or a non-optimal wheelchair can just reverse everything back. We spend so much time on their physique and everything, but then finally, spine issues, various other issues, bed sores. So a mobility device is probably an extension of whatever has been done at a rehab center, or at least maintain whatever was done at the rehab center. So yeah, that's what I would say. We are an extension of whatever you've done with the patient so that they can go back to society. Thank you so much for this opportunity. Thank you, sir, for giving this. And I would want to apologize for the delay in sending these presentations. So thank you so much for following up.
Thank you so much, Mr. Siddharth. So thank you so much we came to know how personalization and individualized solutions can transform mobility and independence to this much. Now let me invite on stage Dr. Rimsha Siddiqui to come and present the memento on behalf of the organizing committee to the speaker. Thank you, Rimsha. So let's move on to the next session. So let me invite Mr. Srinivasa Adepu from Raimo, Mumbai. Mr. Srinivasa is a mechanical engineer by profession, and he holds an M.Tech in mechanical design from IIT Delhi, and has actively contributed to collaborative projects involving AIIMS Delhi and IIT Delhi. And his focus is on development of cutting-edge biomechanical devices. So he's going to present on multi-limb robotic rehabilitation device, highlighting advancements in robotic-assisted therapy. Over to you.
Welcome to Raimo. We are dedicated to aiding movement health recovery for the 2.4 billion people globally who struggle with mobility issues. To put the scale of this industry into perspective, the global spend on physical rehabilitation is nearly 9 times the GDP of Maldives. The numbers are staggering. $54.97 billion is spent annually on physical rehabilitation. Currently, 30% of the global population requires these services, spanning sectors from cardio and pediatric to geriatric, orthopedic, cancer, and neurological care. At Raimo, our primary focus is on neurological rehabilitation. This includes specialized care for brain strokes, spinal cord injuries, Parkinson's, multiple sclerosis, and GPS. The need is urgent. Over 100 million people are affected by neurological ailments globally, with 12 million new stroke cases every year. In India alone, these conditions paralyze 1 million people annually. These people face high costs and require long-term rehabilitation to see results. We solve this by integrating advanced robotics, IoT, computer vision, and AI. Our system automates and gamifies therapy, leading to 25% more repetitions and 9x faster neuroplasticity. This results in higher patient retention and significantly increased confidence. Why now? Because traditional rehab robots are often too expensive and too large for most Indian centers. We address these barriers by focusing on affordability, space efficiency, and reducing technical complexity. Our first product, Mobi L, is a versatile robot for both upper and lower limb training. One device can perform 20 different exercises. It is 10x more affordable than competitors, saves up to 30 minutes per session, and India's most widely accepted and deployed robotic rehab device with 1 patent granted and 5 more under review. We are building India's first digital neuro rehab ecosystem. Our portfolio is expanding, where we recently launched Nudge Cognipods for cognitive training, meant for balance and fall prevention, and future developments like robotic gait trainers and robotic cycles. Our impact is real. We have over 130 customers and impact 500 patients daily. We have reached over 6,000 beneficiaries across 16 states and 30 cities. Notably, 40% of our installations are in Tier 2 cities, and 95% of our customers are first time buyers of rehab technology. Success for us looks like improved lives. We are bringing high tech healthcare to local communities, ensuring that even remote areas have access to advanced movement recovery tools. Our team is led by co founders Chirag Shah, who is the CEO, and Abhishek Rai, who is the CTO, and we are supported by a dedicated staff of 31. We are backed by expert advisors in neuro rehab, finance, and international sales to ensure our clinical and commercial success. Raimo has been recognized by various awards and media outlets for our innovation. Thank you for your time. Let's rediscover mobility together. You can reach us at the contact details shown here.
I would like to play one video. Which just repeat that video. No, Ashad, there's a video in between.
No, there is dot video attached.
There's no video attached.
Yeah. Videos dot video.
Okay, understood. Yeah, sure, no worries. So yeah, hi everyone. Thank you, Saril sir, for inviting me here. And I was known to Saril sir since COVID time. So before Raimo, I was with Flexmotive, and where I made some innovative products. And Saril sir is the one who actually got my product into Sakra, and is very, I know him from very long time, as I mentioned, and he actually doesn't leave any innovator from India not getting into Sakra. So he's the first guy to go in India for if you have some innovative ideas in rehab space. Thank you very much for that. And so currently, Raimo, we have a lot of installations in the country, and we're coming up with a lot of other products also. So first product that we have made has lower torque version, but we are coming up with the higher torque version, which will compete with some global brands in abroad. And we have installations abroad as well. And we got FDA and FDA approval also. And so 90% of the majority of the hospitals in the country have a product. Let's say talk about Manipal, Sakra, Aster, all the groups we have a product. And other products which I mentioned are the Nudge and Mend, which we have a lot of installations in the Tier 1 and Tier 2 cities, which because costing less than 1 lakh, and its affordability is a very big issue in the rehab space. So we continue to actually innovate in the space of affordable solutions for anyone who wants to start the physiotherapy center or rehabilitation right after the college. So yeah, thank you. So if you have any doubts, please, yeah. So 8 lakhs in the market, the customer pricing. It's basically we have 6 spots in it, which it will help you out in the cognition. We sell it to child development centers. A lot of games in it. Usually we test the agility, the speed, the reaction time with the spots. Yeah, sports as well as in the majorly we did not concentrate on the sports part because we are into neuro. So we made it very specific towards the neuro application. Let's talk about kids, which delayed neuro response, and you talk about elderly population, geriatric space. So they need actually some games, which color based might be with some mathematics in it, so which can actually help them out in recovering faster. Yeah, Parkinson also you can take. Yeah. So there is more neuro based. Raimo especially is into neuro based. We don't predominantly get into ortho or any other space. And we're coming up with some new VR also, and then for the both upper body and lower body. And then for the future products, we are trying getting into exoskeletons, the gait trainers, and EMG, the portable EMG we are coming up with. It's very low cost portable EMG, compared with the global brands. And we have a team of around 35 people in Bombay, and we have sales people across the country. And we have the clinical experts also on the panel. help us out in doing the clinical trials and other things. So predominantly we did the most of the clinical trials in the western part of the country, in the Bombay, Pune and those areas. And we continue to innovate in this field. And thanks for your support, and they have a lot of customers of Raimo also here in the hall. So yeah, thank you very much.
Thank you, Mr. Srinivas Sedepu. Now let me invite Dr. Veena Nambiar to come over to the stage and to give a memento to the speaker. So our next speaker for the day is Ms. Roopsha Mukherjee from Galanto Innovations Private Limited, Ahmedabad. She holds a master's in biological engineering from IIT Gandhinagar in 2020. She's co-founded a medtech company, Galanto Innovations, in 2021, with an aim to revolutionize the rehabilitation exercise with their state-of-art technology. She'll be presenting the VR-based hand rehabilitation system, demonstrating the journey from lab to market. Lab, please take over.
Good evening, everybody. I hope everybody is alive. Huh?
Hello, we are Talent Innovation, providing Rehab Relief, a virtual rehabilitation and assessment system designed to improve outcomes in neuro and musculoskeletal rehabilitation. We are based in Gujarat with the team expertise from engineering, healthcare, and rehabilitation sciences. Neurological conditions such as stroke often lead to loss of hand function and finger movement. I'm sure many of us have seen patients struggling with finger opening even after weeks of therapy. And despite repetitive exercises, progress is slow and difficult to measure. As a result, many patients drop out before achieving full recovery. Our solution combined two crucial elements of effective rehabilitation. To drive patients to do rigorous practice of exercise for prolonged duration correctly, we are developing incentivized virtual exercises. And to provide real-time and continuous feedback to both patient and doctor, we are integrating a reliable assessment tool. With Rehab Relief, the patient will be able to track micro-level improvements, reduce dependency on subjective observation, improve patient motivation through biofeedback, and for healthcare setups, it helps to improve patient retention and compliance and support a data-driven training planning. In a typical physiotherapy session, Rehab Relief integrates very smoothly. We begin with patient setup where the glove or module is worn easily within a minute. The glove is designed in such a way that it can fit any hand sizes and can be worn on both left and right hand. Next is baseline assessment, where the system measures the range of motion with high precision up to 0.1 degree resolution, allowing detection of the smallest movement made by the patient. Then, instead of asking the patient to repeat movements blindly, we give them real-time visual feedback. They can actually see their movement improving. They can keep a control of their posture and whether the task has been completed by them or not. At the end, detailed reports are generated, helping therapists document progress and plan future sessions efficiently. Rehab Relief is not just a single product, but a complete rehabilitation solution. This allows you to treat the patient beyond just hand, from shoulder to lower limb, targeting strength, range, coordination, cognition, and reaction time in one ecosystem. Our flagship product, Rehab Relief Glove, enables fine motor training and assessment and is available in two variants. Plus Glove provides detailed assessment of finger, MCP and PIP joints both within actual degree. SC Glove is designed for gross motor training. Both the variants support range of motion assessment and training for all the hand movement. Depending on the patient condition, the therapist can use active mode for voluntary movement, passive mode for patient with no cognition or movement, assist mode for limited movement, mirror mode for neuro re-education. During the therapy, the system automatically tracks repetition, movement accuracy, and functional performance.
Supination.
Rehab relief is being used across physiotherapy clinics, neurorehabilitation center, hospital-based rehab departments. It is effective for stroke rehabilitation, post-traumatic hand injury, spinal cord injury cases, geriatric rehabilitation. The system is portable, easy to use, adaptable, making it suitable for both in-clinic therapy and home-based therapy. This enables continuity of care beyond clinic and support long-term recovery.
मेरे को ये अच्छा लगता है इसलिए यहाँ मेहनत कम पड़ती है और अच्छा होता है यहाँ तो
This is not just theoretical. Patients have shown strong positive feedback. We have observed significant improvement in range of motion and better adherence to therapy program. Here is one of the case study where a patient has shown 20° to 85° of improvement in wrist range of motion, and most importantly, the finger activation has also started appearing. We conducted multiple clinical studies to establish the efficacy of the system on different cohorts of patients in collaboration with leading physiotherapy institutes, and have shown 2 times faster recovery as compared to conventional therapy. Here are the few reports shared by our physiotherapists in their social media handle. Here, one of the patient who had no movement for months, within weeks they started showing voluntary movement. Here is another use case where a post-traumatic injury patient has doubled wrist mobility after therapy. These real-world improvements highlight the potential of our technology and how it is creating an impact on the life of the patient. These are few of the centers who are actively using our patient on regular basis. Ultimately, our mission is simple. We want to bring happiness to patients suffering from disability by transforming the way rehabilitation happens in India for better world tomorrow. And we invite you all to be the part of this exciting and satisfying journey. Thank you.
Yeah. So do we have any questions? So one of my executive demonstrated the upper limb. Similarly, we have modalities for the lower limb also. So now we have system for the complete body, so I can track all of them together. The best part is that because we have integrated functional electrical stimulation with this, so patients who do not have any movement, they can also use it in passive assist and mirror mode. And because functional electrical stimulation can help to reduce spasticity, improve the muscle tone, and help in re-education of the movement. So that is why we are using technologies which are familiar to the physiotherapist in PMR, so that it's easy for it to integrate, and so that the patient will also feel that, yeah, we should stick to the exercise and therefore recover. So I invite you all to be the part of this. If you think this would be interesting, please do contact us so that we can promote more made in India product for our patients. Thank you.
Thank you, Ms. Rupsha, for illustrating how virtual reality is revolutionizing fine motor rehabilitation. Let me invite on stage Dr. Cyril to, on behalf of organizing committee, to give a memento to the presenter.
Thank you so much.
And the PPT. Up next, we have the presentation by Mr. Venkatrao Vallapaneni. So he's a founder and CEO of Robotic, a rehabilitation technology company with a mission to bridge deep tech innovation and clinical outcomes in recovery and human performance. He will speak on Spot, a visual and auditory cue sensor-based device transforming rehabilitation and recovery, which was created by him and is currently validated through clinical collaborations with NIMHANS and KIER. So welcome.
Hope I audible? Okay. So I'm Venkat here, and so what we are going to talk about today is what happens. See, basically what we're talking about is the quality in the rehab, right? So definitely as a professionals, when patient is in the clinic, we all take care of them, and then we know exactly what is happening, right? No, but what happens if after patient goes home, right? The dosage that patient gets is not sufficient at the clinic, right? So you always prescribe some home exercise programs for them to do it. So how do you actually get that into your system, right? So let's take one simple example, quad sets, which is like basic for any knee injuries, right? Be it ACL or TKR, right? So essentially you'll have to do the isometric VMO contraction, and you have to do at least like 3 sets and then 3 times a day and all that. And why it matters is because of AMI, right? The patient himself cannot feel as well. So when the patient is doing at the clinic, definitely you can feel and then you can guide them and all that. But when the patient is doing at home, he cannot even know. So that's basically the challenge that we are trying to address here, right? So even in the clinic, right? So there are 4 clinical blind spots that we are trying to address here. The activation confirmation, whether the quads really fired or not, and then whether the sufficiently hold it for, like, for example, you are asking to hold it for 5 seconds, whether he's holding it or not for all the 10 repetitions across, and then whether the dosage itself is sufficient or not, whether 10 repetitions 5 seconds is okay, or 10 repetition 10 seconds is okay, or do we have to add extra weight as well? And fatigue, right? So when is he actually the dose is sufficient, right? So all these parameters probably, even in the clinic also, they are blind spots. So how are we addressing all this, right? So we are actually trying to just establish the theory here by looking at the literature, right? The proven mechanism is biofeedback improves the motor learning and engagement, and sensor biofeedback post-surgery versus standard care. So it is again established that 79% mean adherence compared to 30 to 60% without the digital engagement. The digital rehab consistency also improves the adherence. So how we are actually trying to do for this particular problem is, like for example, the patient is doing it, and now this is our device which is called a spot, and it has got the distance sensor. So what it can measure is, geometrically, it can measure the distance of an object, right? So now I can know what is the height that the patient has to rise. And then because it's a smart device, it can also tell how long it is held in that position as well. Now if it is lowered, then you can tell that, okay, you are not doing the full extension, right? Terminal knee extension. Or if you are not holding for 5 seconds, then again it can flag it. In fact, actually what we can, what we are talking about, right? So this can be again cheated, right? It's a geometry, right? I can probably rise from the hip flexors also and do it, right? So what actually we can do is we can even put one more spot here and ensure that your knee is pressed, and then still you have the heel raised as well, right? And like another thing that we talked about is the AMI problem, right? You get the biofeedback as well, the lights. The lights indicate whether you have reached into the position and whether you're holding it for 5 seconds, and then after 5 seconds it even gives the beep as well, so that there is no counting inconsistency as well. Okay, so how actually we solve this problem is using 3-step method: plan, guide, and track. Plan is where most of all the clinical workflow is, yeah, sure. Pretty much done. So plan is more like a clinical flow work where you kind of onboard a patient and then take the assessments and then give the prescriptions. In this prescription, this is where we help as well, giving the videos also, instructions on how to place the spot as well, right? And the guide is the real part, which is actually spot helps in giving the light indication, right? And it has also got the video audio buzzer as well and real-time feedback. So here, right, I mean, so now videos are just one time. Actually, videos are now redundant. You are getting the in the moment guidance directly, right? So you don't really need even patients to remember as well. I mean, that's what I think ma'am talked about the music as well, right? So it basically brings that another pathway for you to act upon quickly. And track is the other part where we talked about, you collect all the data and then you kind of infer the actions and then kind of again feedback to the plan part. And these are some of the use cases. Probably you can see it like this is the balance where ataxia patient walks through, stabilizes himself, touches the device. And this is for the Parkinson's where you have to do a cross-limb coordination. So both the devices glow at the same time so that the patient can touch it. And then this is for the stability where on the single leg he stands and then do it. And we took the quad set as an example, right? So it's the same blind spot across every specialty as well, right? Be it MSK and post-surgical or neuromotor rehab or geriatrics for the fall prevention and balance training as well. Same exercise that we have seen for the ACL, balance can be applied for the geriatric as well, right? So this is the question, right? If patients can send you the verified home exercise data for every session, so will you be able to make a better decisions? That is what we are trying to address here. Thank you very much. If I have time, I can just quickly do maybe half a minute as well. And thank you, Dr. Saril, for giving this invitation. These are the devices that you can see lighting up, and then like I said, it has got a distance sensor, and it can act as a movement quality, or it can even act as a spatial gate, or it can even act as a simple timer. And then you keep getting how many taps are done, what is the reaction time and all that. This is more of a spatial gate, not the movement quality that explained for the ACL rehab. Okay, thank you very much. Any questions? Thank you. Thank you, sir.
Thank you for the innovative presentation on sensory-driven rehabilitation support. Now let me, I request the speaker to receive the memento. And now I would like to invite Dr. Karthikeyan, sir, to come over to the dais to give the memento to the speaker. So, ladies and gentlemen, we have come to the end of the...
Good afternoon, everyone. My sincere gratitude to the organizing committee of CAHOCON 2026.
So, we have come to the final Rehab Tech Talk session. So, let me invite Ms. Brinda Pancholi from Multifly Lifestyle Private Limited, Bangalore, bridging innovation and social impact through adaptive clothing and therapy tools for persons with disabilities. She'll present on adaptive clothing for rehab and post-rehab care, highlighting how inclusivity and dignity in rehabilitation matters.
Good afternoon, everyone. My sincere gratitude to the organizing committee of CAHOCON 2026 for inviting me to this pre-conference workshop. As part of the session on innovative rehab tech solutions, I look forward to the discussions today and the next 2 days of the conference. I am Brinda Pancholi, Founder and Chief Empathy Officer at Multiply Lifestyle Private Limited, Bangalore. Multiply is a social enterprise creating innovative, stylish, adaptive clothing for persons with disabilities, patients in treatment and rehabilitation phase, and the elderly. We also design sensory therapy tools for children with autism and ADHD, and we proudly employ persons with disabilities across our organization. Now imagine this. A stroke patient returns home after rehab but still cannot dress independently. A person with spinal cord injury feels embarrassed about visible catheter bag and chooses to stay indoors. These are not isolated cases. In India, nearly 50,000 people sustain spinal cord injury every year, and millions more are navigating cancer, stroke, and critical illnesses. The question is, Are we truly rehabilitating them for real life? Medical recovery is just the first step. The real journey begins after discharge, and it is long, exhausting, and often overlooked. Something as basic as clothing becomes a daily barrier. An IBD patient with stoma bag constantly worries about leakage and hygiene. A person with fractured arm suddenly becomes dependent for dressing, something she has done independently all her life. This leads to lots of dignity, independence, comfort, and confidence. At Multiply, we believe rehabilitation without functional clothing is incomplete. We designed adaptive clothing as extension of therapy. Our garments use Velcro, magnetic buttons, neck closures, zippers. Our garments have openings in the front, side, or back based on ability, mobility, lifestyle, and posture of the person. Our garments are made of breathable fabrics and pressure-free seams for Indian weather conditions. All these make dressing easier for patients, less painful, faster for caregivers. We strongly believe that adaptive clothing is assistive technology, not just fashion. It reduces time, effort, and discomfort and becomes a tool of rehabilitation. Let me bring this alive with some examples. Many persons with spinal cord injury are using our Eurocare trousers, which discreetly conceal catheter tube and a 2-liter urine bag. Today, they are working as doctors, professors, para-athletes, and delivery professionals, traveling and living life independently. Some breast cancer survivors wear our cancer care tops, which are comfortable, drain-friendly, and dignified, going for chemotherapy and stepping out for coffee the same day. For post-surgical and bedridden patients, our adaptive wear significantly reduce the effort required by caregivers and nursing staff. With all these adaptive clothes, what changes? Confidence, participation, and quality of life also change for better. So why do adaptive clothes matter? Because they are a critical missing link in the rehabilitation continuum. They accelerate functional recovery, reduce caregiver burden, restore confidence and dignity. Today, adaptive clothing is being used, trusted and recommended by doctors, occupational therapists and physiotherapists. We are also working with a leading corporate hospital integrating adaptive clothing into neuro rehabilitation protocols. When people regain independence, they return to work, travel, socialize and contribute to society and national economy. At Multiply, we are enabling this shift from survival to dignified living. We are doing our bit. Are you ready to join hands? Let's continue the conversation at CAHOCON. Thank you.
Hi, my name is Justin Jesdas. I'm an Innovation Manager with the Global Disability Innovation Hub, London. I've been a wheelchair user for the last 15, 16 years, a quadriplegic after a car accident, and I'm paralyzed neck downwards, which means I do not have finger function as well. And for the largest part of my disabled life, I even used to drive a car, do para-swimming across the globe, represent India in competitions and all of that. But because I don't have fine motor skills, I was never able to dress up by myself. I was always dependent on somebody in family or somebody who was as a caretaker. A couple of years back, I met Multiply and the folks behind it and got introduced to somebody who's doing it at a professional level. Look at me. A completely customized jean, denims with pockets and absolutely fashionable, and a shirt inside with Velcro. The buttons are fake because I can't button, but the way they've done it is super professional, and there is always this, the feeling of being dapper whenever I walk into a meeting or a business organization or anything. It's fantastic.
Thank you. Good afternoon, everyone. My sincere gratitude to the organ.
Our innovations are mainly from the users themselves or people who are facing difficulties, also from therapists, doctors, parents, special educators, speech therapists, all of them, whoever sees a person facing difficulties or a person herself facing difficulties, they give us inputs and we co-design, co-develop with them. And then we have found around 72 solutions for different conditions. And we are also setting up a stall C190, so please come and visit us. We are also open to newer developments, newer challenges. So looking forward to conversing with you all.
Thank you. Thank you for bringing in such a unique and meaningful dimension to the rehabilitation care. Thank you, ma'am. Now let me invite Dr. Cyril on behalf of the organizing committee to give away the memento to the speaker. So we have come to the end of the Rehab Tech Talk session. So that's a wonderful crowd, and not to forget our virtual delegates also. Thank you so much. And so we have witnessed a remarkable range of innovations from digital health tools and robotics to virtual reality and inclusive design. So as a healthcare professionals, let's embrace innovation, collaborate across disciplines, and most importantly, integrate these solutions into the patient care for a better outcomes. So on behalf of organizing committee, I extend a warm welcome to all the presenters, doctors, entrepreneurs, and innovators for sharing their groundbreaking work and valuable insights. So let us give them a big round of applause. So let's move on to the next session. As we move forward, it's time to reconnect with ourselves. Up next, we have a yoga practice session for rehab professionals. Let's get ready to relax, rejuvenate, and re-energize. So let me invite Dr. D. Gopinath, Senior Physiotherapist, Assistant Physiotherapy HOD, Frontier Lifeline Hospital, Chennai. Please, sir.
Good evening, all. So, just we are talking about yoga for rehabilitation professional. So, Stiram Sugam Asanam, that is steady, comfortable posture. That is the main part of yoga, which is depicted by Patanjali, who is the father of yoga. That is way back by 400 BCD he has given up. So, basically we got pranayama, Pavanmuttasana, and bandhas and mudras and all these and all we gives up. But of course, we are doing here the cardiac rehabilitation. So we have given a specific thing about scrolling. So specific things about why we are implementing to the that is yoga and the cardiac rehabilitation. First, we focus on recovery and strengthening of heart and lungs. The second is combination of exercise with education and respiratory therapy we are giving here, and complements the conventional medical treatments. First, after the patient comes after the surgery to the department, we used to treat them in the chair. So first we used to have some Tadasana, that is mountain pose. The mountain pose we do with the simple thing. Well, the simple thing is that we keep our legs apart, and this is not needed now. I can't able to grab it. Right? Fine. Okay. First inhale well. Then exhale and take the legs up. Okay. And down. So this we do with what is called Tadasana. And then second is what we do is called Kati Chakrasana. Kati Chakra is nothing but we club the hands like this. We go with the side system. Inhalation, go up, 5, and exhalation, we come forward. And inhalation and exhalation. The third is what we do is called Padasana. Padasana is nothing but we have to inhale deeply and exhale and come down. As of you go down as much as you can. Okay? And inhalation, we go up. And this is when we go up. And basic pranayamas, what we do is what is called, first we go with single nostril breathing. That is Nadi Shodhana Pranayama. Nadi is, we call it Samidhu Nadi. Here we focus what is called 3 nadis. One is called Ida and Pingala and Sushna. So what we do in Nadi Shodhana is first what we do is what is called single nostril breathing. So we put up head, neck and spine straight in Chin Mudra position. And then we will keep your Ajna Chakra. Try to take a deep inhalation to the left nostril, close the right nostril, and exhale. This we do for 10 times, right? Like that, the opposite nostril, we do it, we close with the left nostril and we take in the right nostril. First we will teach the single nostril breathing, and now comes the alternative nostril breathing. Alternative nostril breathing we keep here in the Ajna Chakra. Ajna Chakra is in between the forehead, right? That is that is in between the two eyebrows, right? First, we will close the right nostril and take the deep inhalation to the left nostril. Close the left nostril and exhale to the right nostril. And inhale to the right nostril. Exhale to the left. This we will do in. First of all, we do with the Nadi Shodhana Pranayama. And then we do what is called Shitali Pranayama. Shitali Pranayama is nothing but the tongue rolling, the cooling breath. First of all, we sit erect and close the eyes, roll the tongue, inhale through the tongue, right? Close the mouth and exhale through the nose. This is of course 3 or 5 or sometimes depends upon the thing you do it. This is called Shitkari Pranayama, that is with the teeth. Teeth cleansing you do it, right? First we'll cleanse the teeth. Inhale through the mouth and exhale through the nose. Like this we do for 3 or 4 times in a day, right? The first sections. Then at last we go with the Brahmari Pranayama. The Brahmari Pranayama is that you will keep our head, neck and everything straight up. And this is what is called Shanmukhi Mudra, right? So we keep right here, slightly head tilted upward, closing the ear. Take the deep inhalation to the nose. When you exhale, you pronounce the hum. Or we used to pronounce humming sound, like, see that? Like this will give this thing. So what are the effects for this? Is that everything it can be, we can use for the neuroplasticity, we can use for the cardiac insurance, and then for ortho and rehabilitation condition, the first, whatever the exercise you do, we need to go with the mind adherence to the body, right? First, you need to relieve the anxiety, depression, and phobic tendencies. So this type of pranayama is more important. That this first can be done, and then we go with the Pawan Muttasana, that is wind releasing posture. And we got many type of Pawan Muttasana. One is for loosening joints, another called Sakti Bandhasanas, and it's called digestive. There are many things which cannot be right here in this circumference, right? Everybody knows it. And then we don't want any advanced asanas. So in the patients, there should not be any breath hold movements or inverted postures. So first thing is to build up the endurance of the patients. So always we concentrate with water respiratory endurance and then with the muscle endurance. So I think so when this yoga is, we are keeping adjacent to the cardiac rehabilitation or also neuro rehabilitation, whatever thing, I think so it can be worked with the KPA. KPA section attendance and exercise testing measures and then 6-minute walk test, whatever thing you come at. So in after patient going to the home also, that participation in the exercise sessions is more. And then when you come about with the medical adherence, the patients, most of the patients is not taking the medicines well. So this, when you relieve the anxieties, everything else, you are taking the medicines well. And the patient readmission for 1 year after this, when you do with the cardiac rehabilitation, with this yoga, I think so there is no readmissions. Because we are doing more than 10 years here. And what is our thing, prescriptions of treatment here is it? We do 12 sections of 3 months. So with adjacent to the yoga, it is absolutely proven well that there is no readmission for 1 year. That is the statistics here what we have, but there is no high view. So when you do listen with the yoga, I think so that the patient, whether he's an ortho or a neuro or a cardiac, whatever thing, it can be very good. So for here, no, the simple thing I do with the heart here, right? Okay, the simple mantra what we do with this what is it? For heart, we use say about the Hananta chakra. So Hananta chakra, we use the word hum. So hum. So mind, there is mind resonance technique is always important for our mind also. So there is a clinical evidence that most of the things that the beta waves are more pronounced in ECG studies, right? So I'll give a live studies about what. Okay. First, sit erect and right head approach. So inhale well. Pronounce the word hum. Focusing on the heart chakra, right? First you can hear the sound and then you can visualize your breathing pattern. Okay. Then another time I can inhale well. This can pronounce for 5 or 7 times. Right? So another thing is that it is also very important. How it is very important for the pulmonary rehabilitation is that the hum has 3 words. One is called ah, oo, in. Okay. Ah is for upper respiratory tract. Oo is for middle respiratory tract. Him is for the lower respiratory tract. It is well proved in Sadhguru's principles. Sadhguru has given a very good evaluation. So basic, most of the persons cannot do Simasana. They stand out and say ha ha ha. Nobody can do. Most of the patients doesn't do. The correct patients because tunnel injuries and everything, the brain injuries, everything. Simple thing you can make the patient to sit and say hum, hum like that. Or we can say or 5 times or say ooh. So when you take pre or post, BP, saturation, heart rate variability, absolutely one that is saturation will be increased 3 or 4%, heart rate variability is actually good. So BP also will be reduced, especially diastolic is very much reduced. 8 to 10 mm is good. So these are things we can specialize. So other thing is that we come to the end of the dhyana and dharana. So concentration and meditations. So I give a simple word with Sadhguru's how we use of it. So sit straight, get your neck straight, focus on the chakra. Think that when you inhale, you take that I am not the body. So exhale, you say that I am not universe. So this is how we can do. Just for the time being. Sit upright, stay neck up, take a deep inhalation, focus on the forehead, that's Rajna chakra. You say that I am not the body. Inhale, and then exhale, you say that I am not universe. I am not the body. I am not the body. So this at least 5 to 7 times a day you can do it. Very good. So when you talk about mudras in a heart patient we will do is what's called Hriday mudra. So Hriday mudra is nothing but we have to keep this in this finger, control it and keep inside the thumb. And this 3 fingers on straight and the same as it is. Nothing to think about that. So keep using the body straight. Head up and inhale. Exhale. This focus should be on the breathing pattern. That's all. So keep inhale. Inhale. If you're not able to do this, nothing to worry about it. Just keep it in. Mudras is nothing but the gestures. It has a network of like 5G, 6G, everything. So it connects every network to the nerves into the brains. So it controls your nerves.
Thank you so much, sir, for a rejuvenating session. Now let me invite on stage Dr. Veena Nambiar to
felicitate our speaker. So, ladies and gentlemen, every good things come to an end. So, now let's go to the validatory session. So, let me invite on stage Dr. Rimsha Siddiqui to take over.
Thank you, Dr. Jeva. Well, you rightly said all beautiful things come to an end, but I believe this end is a new beginning. So, I'm going to start with valedictory, and the most exciting part. Okay, so I think I'm going to start with the most exciting part of the evening, the prizes. I'm sure a lot of you must have participated. So to give away the prizes, I would like to request the core members of the Rehab Quality Forum to please come on stage. Dr. Jeva, Dr. Veena, Dr. Saril, Dr. Avinash, please come on stage. Dr. Prasanna, do we have you here? Dr. Komal? Yeah, please come. Well, though we had power-packed presentations today, and I feel so happy that all of our revered faculty members could join us here. But the audience have voted for the most impactful speaker of the day. Okay? Sorry. So, we have a tie for the most impactful speakers of the day. Any guesses from the audience? Any guesses from the audience? Whom you have voted? You don't want to reveal that, really? So let me put out the name. The first name is Dr. R. Karthikeyan. Please give a big hand. Dr. R. Karthikeyan, please come forward. And Dr. Ashutosh U. Nayak. Yeah, yes, please put your hands together as we felicitate both of our revered faculties and speakers. Dr. Ashutosh, please come. It's a tie. So there's a tie actually.
Okay. So we will send it across to you. Please.
We can take it for a photo. For photo, can we? Yes.
Thank you.
So moving on to the next category, we have the e-poster competition. We have two categories in this poster competition. First is the clinician award. The other category is the student award. So I'm calling for the first clinician award. You have kept it so discreet, even I was not aware of the names. Yes, so the clinician category, Dr. Subramaniam R. He's a neurophysiotherapist, Sakra World Hospital, Bangalore. Please give a big round of applause. He's the winner of e-poster presentation. The theme was rehabilitation, quality and safety. Now the first runner-up in this category is Dr. Shilpa Pandit and Dr. Pranav Vishwanathan. They are the speech language pathologists, Sakra World Hospital, Bangalore. Can anybody else take on their behalf? Yeah, Dr. Komal can, yeah, you can take on their behalf. So the second runner-up award goes to Dr. Karthikeyan T, Associate Professor, Department of Physiotherapy, Gurugram University, Gurugram, Haryana. Do we have him here? I think he has joined us online. Please give a big round of applause. I'm sure he must be watching us online. Now the second category is the student category. I'll start from second runner-up. Do we have Dr. Vaishnavi from Ramaiah College of Physiotherapy, Bangalore? Second runner-up. So I think Dr. Veena, can you take her award? Yeah. So Dr. Veena will take Dr. Vaishnavi's award. There's actually a tie on the second runner-up award. So Dr. Vaishnavi and Anshula Chaudhary and Bhanita Medhi. Department of Physiotherapy, Chitkara School of Health Sciences, Chitkara University, Punjab. Now the first runner-up in this category is Hiresh K. He is a BPT final year student, Jaya College of Physiotherapy, Chennai. Do we have you here? Hiresh? Yes, please come on stage. Please keep the claps coming and thank you. So the winner of this category is Mohammad Abdullah. He is a BPT final year student from UCA College of Paramedical Science, Chennai. Chennai, you have to give a big round of applause. He's from your city. Yes. So the next category is best reel competition. We have just one person in this. The winner is Amrita R. Nair, Yajna J. Amin, and Shruti Jain, Keyur Baggi. They are the second year MPT Cardio and Pulmonary student from MS Ramaiah College of Physiotherapy, Bangalore. Please give a big hand. And I believe they are not here. They must have joined virtually. I request Dr. Veena to take the awards. So now, I think this is one of, yeah. So let's first call upon the people who won the quiz. We had 3 people, yes. So, I just need the names of the quiz competition. Names of, Dr. Kumar, can I have the names of them? Someone took a photo. I have the photo. This is the winner. So may I call upon Dr. S. Benedict, Kinslin Suresh. Please come on stage and give him a big round of applause. I think he was very good with his fingers, plus the knowledge. Before I could even think, the answers were already on the screen. Trophy दीजिए. What's your hair? What's your hair? Yes, we have 2 people. 2 more people. Yeah? Parvati. Yeah? So the next in line is Dr. S. Parvati. You actually changed the game. There were other names, and then last it was Dr. S. Parvati. Please give a big round of applause to Dr. S. Parvati. Oh, yes. All right, so we have now the last category of the award, Rehab Quality Champion Award. So I think this is one of the most awaited categories of the today's evening. So let me just. So we have got 4 entries on this, though we decided on 3, but we had such an amazing proposals on this. So the first prize, I should not call it first, actually they all are winners and under the same category. The first I would like to call Dr. P. Haripriya, HOD Physiotherapy and Rehabilitation, Senior Manager OPD, Tri-Life Hospitals, Bangalore. Ma'am, congratulations.
So, namaste to all. I think they have introduced me as Hari Priya. I head the physiotherapy and the neuro rehabilitation Tri-Life Hospital, Bangalore. So, I would like to thank God, because without God, I would not have been here first. My parents, because of them, I've been able to come into this world. My family, who had been very supportive, and my ex-colleagues, especially I have to tell Saril, who has been behind me, he was just poking me. He told, "Madam, please self-nominate, self-nominate." I think a big thank to you, Saril. Yeah, I think he was the one who, I was not in a thing to nominate myself, but he was the one who encouraged me and who supported me in all my, the nominations. And thank you, Saril. And my ex-colleagues who had given me a LOR, to tell that, okay, yeah, ma'am, you're there. So that is one thing which I want to give a big thanks to my ex-colleagues and my present hospital family, because we are a family. We don't call ourselves a Tri-Life Hospital. We call them, each of them, we have a family culture here. We are bonded to each other. So I would try to, I want to thank my co-founders, Dr. Prashant sir and Dr. Shafiq sir, who has given me an opportunity to be with them. It is almost now, I have completed 8 years of my service, total 33 years of my service in my field of physical medicine, rehabilitation, physiotherapy. So, and not the least, like all my people who have been, be there here today to be a part of this celebration. And that's it. And I think I feel very proud and honored. And all my 33 years of blood and sweat, that's come out today, that I feel very proud of it. Thank you so much. Thank you for this honor, and I'll be always to you. I bow my head to all of you.
So we have Dr. Palak Dangla, Chief Physiotherapist, Physical Medicine and Rehab, Aster RV Hospital, Bangalore. May I now have the honor of inviting on stage Dr. Sudhakar Govindsamy, Head of Program, Senior Physiotherapist, Motivation India, Bangalore. Please put your hands together as we welcome Dr. Sudhakar on stage.
So, good evening, everyone. Thanks, Cyril and team, for nominating and selecting me in this particular award. And my name is Sudhakar. I'm also a physiotherapist, but I'm working as a seating and wheelchair specialist past 17 years. And when you say the wheelchairs and seatings, it may be like strange. I have traveled across India and abroad as well. But many times I see what I'm just doing, nuts and bolts and all those things. But I have to just hold the legs and hands. But many times when I see, it is not just a wheels what I was holding actually. I was just holding the life of the people and the hopes of the families. So that's what brought me here. And when you say the wheelchairs or the seating solutions, it is not just a mechanical parts. Many times what happens, we are all excellent therapists or excellent rehabilitation professionals. We uplift the people till the gate of our center. Maybe beyond that, what's happening when you just go back and see the child is lying down always at the home, or the person or adult just sitting inside the home looking at the four wall. That's what is happening. So the assistive device, the assistive technology, which brings back the person meeting the friends, going out for a family functions, or just go for a walk. So that's what I do, and I hope there is a huge scope in this particular sector. And in India, there are very, very least people like Saril promoting this this specialization, and each one of the therapists or each one of the rehabilitation professionals can just connect this end mile to give the life of the people. So thank you so much, acknowledging, and thank you everyone.
Dr. Sudhakar, I must say that you're not giving wheels to the patients, you're giving wings to the patients. Thank you for making so many patients functionally independent. So I think I miss Dr. Palak. You can't leave without saying a few words. So please come on stage. Please, once again, Dr. Palak.
Hi, good evening all. So first of all, I would like to thank Almighty and my parents because it's a very special occasion for me to, the work that we have done in the field of rehab to get recognized for it. So thanks a lot to my parents and Almighty. I would like to thank all my mentors, and Dr. Haripriya has been one of the mentors. I was at Manipal with ma'am 15 years ago, and today we just met on the flight after so long. I think it's all because of Dr. Saril. We have worked with Dr. Saril as well at Manipal again. So post that, I finished my postgrad over there, and then I was working at Kokilaben Ambani for a couple of years. And it's been 10 years now since I've moved to Bangalore, and I'm with Aster RV Hospital. So I think today it's like a culmination of all the hard work that I've done in the field of rehab, and uplifting and creating awareness that how we can make patients independent and functional, especially when it comes to stroke and paralysis. So thanks a lot to Kaho, thanks a lot to the entire committee, and great thanks to Dr. Saril to push for applying for nomination. So thanks again. Thank you.
So this entry was very special to us. You can figure out the reach of Kaho and the efforts of the Dr. Saril and other members. Dr. Iman Abdul Rahim Al Janahi, he's a physiotherapist, health support system department. He's from UAE. So he's also one of us. So now let's give a big hand. I hope he must be seeing us online. Yes. Before I go ahead with the vote of thanks, I would like to acknowledge the efforts of one very special member who has been always doing all the stuff and still staying, in the background. Let's give a big hand to Dr. Jeba for bringing us together, doing a lot of job, a lot of things. She does it so silently. Let's give a huge shout out to Dr. Jeba. And I request Dr. Saril to please present a vote of thanks to her.
I would like Saril to felicitate Rimsha here. She has been on it from the morning when we started, and still her Josh goes on till the end of the day. So, Saril, please.
So my dear friends, as the year goes by, I just want to encourage all of you, the next year, 2027, when we meet in Mumbai, request all of you to please nominate yourself or your friends. You would have realized that the Rehab Quality Champion Award is the Oscar for a therapist, you know, or a PMR doctor, or a speech therapist, or an occupational therapist, any of us actually. There are, usually when you go to IAP, you have only physiotherapist. No occupational therapy is allowed inside the IAP, and vice versa. In IOTA, no physiotherapist is allowed, right? So I can proudly say that Kaho Global Rehab Forum is the only place and the first initiative in the world, in the globe, to get all of us together to really, really support each other and grow together. So Rehab Quality Champion Award is very important. It really salutes. The jury actually shared with me that they had a tough time trying to finalize that who is better than each one. So it is a hard-earned one. Each of us are a rehab quality champion, but some of us really stand out. The kind of contributions that they make to the society, the kind of work that they do honestly, and most importantly, I must say, these 3 people or 4 people that we have seen today, one virtually who has joined from Dubai, all these 4 people silently do this revolution. They don't make much fuss about it, so we may not have met them in most of the conferences. Probably they have been working very hard. So we really stand together to honor every single individual who contribute to rehab. And that's our vision, and that is what we are trying to do. So I would say it is our Oscars that we give it away to these winners. Thank you so much. Please continue inspiring generations to come. Like I would say, I know Dr. Haripriya, her daughter is a physiotherapy student. So when I say generations to come, it goes to another level altogether actually. So imagine how much passion they have that you choose your daughter or son also to become your own profession, right? So these are all exemplary actions. A big salute to all of you. Thank you so much.
So let's come to a conclusion to this ceremony. I must say that it is indeed my honor to host such an august gathering. We should give a big round of applause to all the people who are sitting over here. No conference is actually complete without such a great audience. So I believe the only people who make a successful conference is participants, candidates who travel from so far, from various places, leave their job aside, rush to the auditorium. So it's you who deserve a huge and heartfelt gratitude from our side. So I would like to present vote of thanks on behalf of core members of Rehab Quality Forum. Thank you so much for joining us here, making this event successful. And you were all very curious, and it was an amazing interaction with you. I always find vote of thanks very overwhelming because I don't like to skip names for those who worked really hard, but please forgive me if I do. I would like to be very, very thankful to the Frontier Lifeline Hospital, especially Sandhya ma'am and Dr. Sanjay for providing this platform to connect. So my heartfelt thanks to both of them. The lovely team they both have. So I must compliment the academic committee who have been working in the background, doing all the stuff. We have had groups, we were doing conversations. You might not know that they have been working really, really hard. So big round of applause for Sandhya ma'am and team. That includes academic committee. The IT person, Mr. Bam, Dhanraj, and Jora. Thank you so much for such a smooth coordination. There was no technical glitches. I think in every conference I say that there should be a technical glitch. It's like a black dot for, what do you call that? Evil eye. Yeah. So today there was no such thing. Everything went too smooth. The kudos to IT team of Frontier Lifeline Hospital. Thank you so much for the housekeeping department for keeping it very smooth and clean. Transport department for picking us up and on time. They brought us on time, and I'm sure they're going to drop us back on time. The Department of Food and Beverages, thank you for providing such a nice biryani. I thoroughly enjoyed. I was too hungry. Maintenance department, and last but never the least, the students who are in the white saris. They worked really hard right from the morning. I'm sure they must be working before that. Thank you so much, all of you. This wouldn't have been possible without the inspiration and vision of Dr. Lalu Joseph and Dr. Vijay Agarwal. So under their aegis, we are here, we are connected. I think it's their vision that brought us together. So I would like to present a vote of thanks to them as well. All these sponsors, who have been supporting us directly, indirectly. So million thanks to you. You make us do and connect and come to all the ways, and gather around here. So thank you so much for your sponsorships. Thank you for your support. And we really look forward to you for further collaborations. Thank you once again. And Dr. Saril, though you are a part of my team, and but still I would like to say thank you for pushing us forward, motivating us always, and he's always with a huge smile, forgets a lot of my mistakes as well. Even when I crib a lot, he is very patient. He's an amazing person, thanks to you as well. And I wish to join you all in Mumbai 2027. Yes, that's right. So see you all. Let's make it as a great and grand event. I wish you all the best and wish to join you. Dr. Veena, would you like to say something? Oh, yes. So see, ma'am is always on foot. She's just reminded me that you can collect your certificate from the 4th floor, from where you got your caricature done. Please collect your certificates from there. We would love to have a group photograph with you, all of you. Can we gather around here, or we should go to 4th floor? Whatever you say. It's limited. Well, I think it'll take some time. Yeah. Can we take a group photograph over here? Yes, please come forward. Let's take a picture and let's try to adjust in this. Yeah. Canteen is better. Yeah. Dr. Jeba. Group photo.